The subcommittee will come to order. Before I recognize myself for opening statement, I know that we all got the news this weekend that our chair is going to do other things, and and I will tell you, it's absolutely a pleasure to serve with you as chair. I know all of us don't get a chance to say that, but I have the microphone now, so I will. And it is just an honor, and your leadership of this committee has been wonderful. I think both sides, I will say that you've been a great leader. I know we haven't always disagreed on everything. I agree with both sides. I agree with you, but but I would say that's the lead. It was a good save, wasn't it? A good save. But I know that I think everybody here, and I speak for everyone, is that what a class act you are, and how much you're going to be missed. And I know, I'm sure Anna, you want a minute, but since we have before we kick off.
Thank you, Mr. Chairman. Well, the news that went out over the weekend, Madam Chairwoman, I think really took all of us back. It wasn't something that anyone anticipated. You've served in the House for 20 years, 2 decades, 6 years on Energy and Commerce. At the beginning of this Congress, we celebrated the first woman in the history of this committee to become the chairwoman. And that historical fact will remain. That historical fact will remain. So we wish you everything good, that God will continue to bless you, your family. Thank you for your leadership of this committee. Thank you for your friendship. We have the rest of this year, so let's get more done, okay?
Absolutely.
Yeah, thank you, thank you, thank you.
We're going to keep charging forward. So thank you. And again, thank you for your class and everything. So now we will begin opening statements for members, and I will recognize myself for 5 minutes. Thank you to our witnesses for being before the subcommittee today. The bills in front of us today are designed to promote greater and improve access to care for Americans and their families. They are also complementary to our work on lowering health care costs for all Americans that we've worked together bipartisan moving forward with that. We're considering legislation that will continue programs to detect, to diagnose, and to treat chronic diseases and health conditions at earlier stages, improve the quality of life for individuals with disabilities, help ensure Americans in rural communities have access to life-saving care, and provide additional resources to assist in the development of cutting-edge treatments for debilitating health conditions. Today's hearing will help inform our policy making as we explore how current programs are working and if any gaps that exist may be addressed to improve the quality of life for millions across the country. For example, my bipartisan bill, HR 7218, the Building Our Largest Dementia Infrastructure for Alzheimer's Reauthorization, or BOLD Act, would continue programming to ensure individuals living with Alzheimer's have access to the highest quality of health care while building on efforts to identify and diagnose the disease sooner. The BOLD Reauthorization Act also includes educational resources for caregivers to help ease the challenges for those caring for the loved ones with this vicious disease. These continued investments are even more important now that we have treatments to slow the progression of Alzheimer's and will help to ensure patients and their families have more time together. And I say that as one who just lost my mother-in-law to that disease in October. I would like to thank Representative Tonko for leading this legislation with me, and I look forward to working to get this important bill reauthorized this year. Another crucial bill we are considering today is the Charlotte Woodward Organ Transplant Discrimination Prevention Act that's led by Representatives Kamek and Dingell, which will prohibit healthcare providers and other entities from denying or restricting an individual's access to organ transplants solely on the basis of the individual's disability. This builds on work we did last week, led by Chair Rogers, who has been a champion for individuals with disabilities by passing the Protected Healthcare for All Patients Act out of the House of Representatives to ensure individuals with disabilities are treated fairly and are able to access the treatments they need. We'll also consider the Deandra Dixon Include Project Act, which will authorize current programs at the NIH to continue cutting-edge research on Down syndrome and address gaps in current research initiatives. The Include project will continue to facilitate improved coordination across NIH and build upon research that will improve the quality of life for those living with Down syndrome. Other bills being considered today are designed to improve access to care for individuals in rural communities, as well as diagnose potentially fatal yet treatable chronic diseases such as heart disease and certain cancers. The Siren Reauthorization Act, led by Representative David Joyce, will continue providing resources for rural emergency medical providers to ensure they can maintain their essential services. H.R. 7189 will reauthorize programs to help address gaps in care for individuals with congenital heart disease. Efforts like this have helped to ensure over 90% of kids who are diagnosed with congenital heart disease live well into adulthood. Many of the bills we're considering will promote greater access to care, facilitate earlier detection, diagnosis, and interventions, and help individuals live longer and healthier lives. Thank you to all my colleagues who have worked hard to get the legislation before us today. I appreciate all of our panelists for being before us today, and I thank everybody for their leadership in working on these policies. And I will yield back, and the chair will now recognize the ranking member, Ms. Eshoo, for 5 minutes for questions, or for opening statements, sorry.
Our opening statement. Thank you, Mr. Chairman, and good morning, colleagues, and happy Valentine's Day to everyone. It was always a wonderful celebration in our household because it was my mother and father's wedding anniversary. So today, the subcommittee will consider 19 bills to authorize critical public health programs that support and improve the health and well-being of children, of adults, and of caregivers. I'm so pleased the majority of the bills, 18 of the 19 bills that we're taking up today, are bipartisan. Each bill before us today supports individuals and families at the most vulnerable times in their lives. I'm sure most members of our subcommittee, I think all members of this subcommittee, have experienced at least one, if not more, of these vulnerable moments in their lives. I have, and so have most Americans. Emergencies involving children are terrifying, most especially for their parents. The Emergency Medical Services for Children Reauthorization Act, led by Representative Castor, gives parents peace of mind by reauthorizing the only federal program dedicated to enhancing medical care for children during an emergency. Representative Cardenas's Lifespan Respite Authorization Act supports people who serve as the primary caregiver for an aging or sick loved one. Being an unpaid caregiver is physically and mentally exhausting. Reauthorizing this program will ensure caregivers get a temporary break. Finally, the Shine for Autumn Act, introduced by Representatives Castor and Kelly, closes gaps in stillbirth data, research, and awareness to ensure every mother can have a healthy pregnancy and life with their baby. So many Americans experience one of these vulnerable moments each day. If someone you love was facing health challenges or in trouble, I think each one of us would go to the ends of the earth to help them. We should give families confidence that when they seek out help, these programs will be there for them. Together, these bills bring us closer to the goal of quality health care for all Americans and show the vital importance of federal agencies such as the CDC and HRSA. Our 7 witnesses, and thank you for being here today, will explain what people in these moments need and how these bills can help. I look forward to hearing your recommendations for how Congress can maintain and improve these essential programs. I now would like to yield the remainder of my time to Congressman Tonko. He leads 3 bills before our subcommittee today, which offer crucial resources to detect Alzheimer's disease early, reduce risks, and support the caregivers who take care of their loved ones.
Thank you, Ranking Member Eshoo, for yielding, and I thank you and Chair Guthrie for your focus on Alzheimer's in today's hearing. And I thank you all, all of our witnesses for their expertise and their insights shared this morning. Special thanks to Dr. Joanne Pike, CEO of the Alzheimer's Association and CEO of the Alzheimer's Impact Movement, for joining us today and for the terrific work that you do and the great leadership you provide. I'm honored to be in the fight to end Alzheimer's. I've carried many of the bills for the organization and proud of that fact. As was indicated, many families have been impacted by this disease. I know so many in our community and around the nation who are suffering from this disease and whose families carry a heavy burden indeed. Alzheimer's is the most common form of dementia and is unfortunately growing and growing fast. Unfortunately, 1 in 3 seniors dies with Alzheimer's or another dementia. In 2023, Alzheimer's and other dementias cost our nation an estimated $345 billion. It's something that we should be very noteworthy of. Ever since my first days in Congress, I've pushed for strong action to support those living with Alzheimer's by driving medical research, federal coordination, early detection, and public health infrastructure, and of course, support for caregivers. I invite all of my colleagues here to support NAPA reauthorization, bold reauthorization, and the Alzheimer's Accountability and Investment Act to continue our fight against Alzheimer's and to support the millions of Americans living with this devastating disease. Again, I thank the ranking member for yielding, and together, let's provide much-needed hope. Thank you, and I yield back.
Gentleman yields back to the gentlelady, and the gentlelady yields back. And I will now recognize the chair of the full committee, Chair Rogers, for 5 minutes for her opening statement.
Thank you, Mr. Chairman. First, just let me say thank you to all of you, to the chair, to the ranking member, to my colleagues, to the extraordinary staff. Given my announcement last week, I am blessed. I am blessed. And it has been a tremendous blessing to lead this committee, just extraordinary. I can testify that being the chair of the House Energy and Commerce Committee, the best committee on Capitol Hill, is the best position in the House, and it's been a privilege and honor for me to lead. And I'll just say, you know what? We're going to finish strong. We have a whole year ahead of us, and we have a lot of work to do. And I look forward to working with all of you on important issues, including the issues that are before us today, the bills before the Health Subcommittee. So just a big thank you, everyone. I've said it many times, and I will continue to say that this committee is extraordinary because it has a rich history of plowing the hard ground necessary to legislate. And it means coming together to get things done, to get results. And I'm proud of our efforts so far this Congress, like the Lowering Costs, More Transparency Act, which are fundamental to driving down the cost of care and fixing our broken healthcare system. And today we're focusing on 19 bipartisan bills that support patients, caregivers, and healthcare providers. Specifically, we will examine proposals to help improve our understanding of various diseases, disabilities, chronic conditions, and stillbirths. We'll look at legislation to continue support for emergency medical services and healthcare providers, to reauthorize respite care resources for family caregivers, and to prevent organ transplant candidates from being denied a transplant based solely on having a disability. I look forward to hearing from our witnesses today. Thank you for being here about the importance of these programs. I especially am excited to be moving forward on the Deandra Dixon Include Project Act of 2024 that I've introduced alongside with Representative Diana DeGette, Tom Cole, Rosa DeLauro, and Eleanor Holmes Norton, and I expect all of you to co-sponsor this bill. No, anyway, you all know that my mission here has been to improve the lives of individuals with disabilities. And that's why I'm proud to champion this bill that would provide important congressional oversight and direction for the Include Project at the National Institutes of Health. It was established by a congressional directive in 2018, Include, and it's also known as the investigation of co-occurring conditions across the lifespan to understand Down Syndrome Project. And it conducts research on critical health and quality of life needs for individuals with Down syndrome throughout their lives. And at the time Include was established, Down syndrome was among the least funded genetic condition at NIH, despite being the most common chromosome abnormality. So I just want to underscore how important it was that Congress took action to make sure that Down syndrome was a priority at NIH. You know, the individuals with Down syndrome are affected by many of the same diseases and conditions that we're examining across the board. The good news is that individuals with Down syndrome are living longer than ever. but they're developing Alzheimer's or dementias like at 100%. There's no case of an individual with Down syndrome having a tumor cancer, yet they have a higher likelihood of juvenile leukemia. And so when we are looking at research that benefits those with Down syndrome, we also have the potential, as we continue to focus on the 21st chromosome and some of the specific issues related to those with Down syndrome, that will benefit millions of people who battle these other conditions, whether it's Alzheimer's, cancer, heart conditions, that are not just, that are common but hardly limited to people with Down syndrome. So this is bipartisan legislation directing NIH to continue this important work on Down syndrome research to help everyone with Down syndrome and their families. And, I'll just say once again, we have a lot of work ahead of us. These are important bipartisan bills, and I look forward to continuing to work with each one of you over the rest of this Congress to continue to improve the lives of the people that we have the honor and privilege of representing all across this country. A big thank you again to the witnesses for traveling, for being here today, sharing your insights and expertise. We look forward to your testimony, and with that, I yield back.
Thank you. The chair yields back. The chair will now recognize the ranking member of the full committee, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Chairman. I want to start by praising Chair Kathy Rogers, who was, of course, the first woman to chair the Energy and Commerce Committee in its more than 200-year history. Kathy, I've really enjoyed working with you over the years, but especially the last 3 years as you served both as ranking member and as now as the chair. I think you've made a lot of progress in this committee's effort to accomplish things, including this year, the bipartisan legislation to lower healthcare costs and increase transparency in hospital pricings. You're leaving. I still don't want you to leave, but I always say that, and then nobody listens to me. But, it's going to be a big loss for Congress and this committee. But I don't want to dwell on it too much because we still have the rest of the year and we can still accomplish a lot. So, exactly. So I'm going to leave it at that for today and talk about our work today, which is to consider 18 bipartisan bills to reauthorize or create several important public health programs. This subcommittee will hear from a diverse panel of expert witnesses representing families affected by mental health, trauma, and discrimination. And I'm pleased that we'll be discussing H.R. 6829, the Cardiomyopathy Health Education Awareness Research and Training in Schools Act, or the HEARTS Act, which I introduced in December. The HEARTS Act will save lives by increasing awareness of cardiomyopathy and helping prepare schools to deal with cardiac emergencies when they occur. When I announced the introduction of this bill, I was joined by members of 2 New Jersey families that each tragically lost a young son to this condition during high school sporting events. The legislation directs the Secretary of Health and Human Services to develop guidelines on the placement of automated external defibrillators, or AEDs, in schools, and to provide resources to help schools create and implement a cardiac emergency response plan. And the use of AEDs during a cardiac emergency increases the chance of survival from 5% to over 50%, which could save up to 40,000 lives each year. Aside from the HEARTS Act, there are many bills before us today that reauthorize important public health initiatives. I'll start with the need to reauthorize several autism spectrum disorder programs, as autism is one of the fastest growing developmental disorders, affecting 1 in 36 children in our nation. Today, we'll hear the impact of 3 important bills to extend funding for family-led organizations to help children with special health care needs. The bills reauthorize crucial research, training, and monitoring for autism research until 2029, and reauthorize respite care provided to children and adults with special needs. Another challenge before us is helping Americans with Alzheimer's disease. We know an estimated 6.7 million Americans over the age of 65 are living with Alzheimer's dementia, and it's the 5th leading cause of death for people 65 and older. We'll discuss 3 bills that will support continued coordination of federal planning to promote healthy aging, healthy aging and bolster the National Alzheimer's Project and support early detection, diagnosis, and dementia caregiving. We're also discussing legislation that will provide support to our nation's healthcare providers who have experienced unprecedented levels of stress and burnout that was only exacerbated by the COVID-19 pandemic. Today, we'll hear directly from a family who has turned tragedy into life-saving relief for our healthcare professionals by creating a program to implement evidence-based strategies to reduce and prevent suicide, burnout, and substance use disorders among those who are on the front lines of patient care. And we'll also examine bills to reauthorize grant funding for improving emergency medical services in rural areas, supporting our poison control grant program, and providing states with access to services and support for people with traumatic brain injuries. And we'll discuss bipartisan bills to support a broad variety of public health initiatives focused on stillbirth, Down syndrome, and cancer screenings for women. So there's a lot going on today, all very positive, and I look forward to hearing from our witnesses about the impact these programs have on the American people and our overall public health infrastructure. So with that, Mr. Chairman, I yield back the balance of my time.
The gentleman yields back. That concludes members' opening statements. We'll now go to our witness opening statements. I'll introduce each witness, and I'll call on you one by one for your 5 minutes. So our first witness will be Dr. Andy Shih, Chief Science Officer of Autism Speaks. Mr. Corey Feist, co-founder and CEO, Dr. Lorna Breen Heroes Foundation. Dr. Joanna Pike, President and CEO of Alzheimer's Association. Dr. Gordon Tomaselli, former President of the American Heart Association. Ms. Michelle Witten, President, CEO, and co-founder of Global Down Syndrome Foundation. Mr. Randy Strozik, President of American Ambulance Association. And Dr. Christiana Anuzita, Senior Vice President of Extramural Discovery Science, American Cancer Society. So thank you all for being here. You'll have 5 minutes for your opening statement. 4 minutes into your opening segment, you'll see a green light to begin with, and after 4 minutes, a yellow light, and gives you a signal you got a minute left, and when you see the red light, it's time to wrap up. So we appreciate you all being here, and we'll begin by recognizing Dr. Shih for 5 minutes for your opening statement.
Thank you, Mr. Chairman. Good morning. Happy Valentine's Day to all members of the committee. Thank you, Chairman Guthrie, Ranking Member Eshoo, Chair McMorris Rogers, and Ranking Member Pallone, and all members of the committee holding this hearing for inviting me to testify on the Autism Cares Act of 2024. I would also like to thank Representative Chris Smith and Representative Henry Kohler for their leadership in introducing this important bill. I am Dr. Andy Shih, Chief Science Officer for Autism Speaks, a national nonprofit organization dedicated to creating an inclusive world for people with autism throughout their lifespan. We do this through advocacy, services, support, research, and advances in care. This committee has long recognized the urgent need for investment in autism research and training programs to ensure better care and well-being for autistic people. The Autism Care Act is a remarkable example of bipartisan collaboration can propel progress. The most recent data indicate 1 in 36 children and 1 in 45 adults are on the autism spectrum in the United States. Like everyone else, each autistic person has unique strengths and challenges. Over the past 2 decades, we have seen fundamental change in our understanding of autism and, most important, acceptance of autistic people. At the same time, in large part due to research that the Autism Care Act has funded, we have a much clearer picture of the significant disparity that autistic people experience in terms of access to quality health care, daily life support and services, and employment opportunities. Know that autistic people struggle with myriad of co-occurring health conditions at a much higher rate. For example, about 3/4 of autistic children have 1 or more mental health conditions. Inextricably linked to these challenges are that many of these inequities that exist within our society are exacerbated for people with autism, which can often lead to poorer outcomes. To be sure, we have come a long way. Around 30 years ago, the NIH was spending less than $10 million a year on autism research, and autism was thought to be extraordinarily rare. Since the first version of the Autism Cares Act was signed into law, we have seen tremendous progress. The Autism Cares Act has been the single greatest driver of autism research and investment, training program for future health professionals who serve autistic people, led to countless advancements in our understanding of autism, from the biology of the condition to the medical complexity that affect the autistic individual at much higher rates. To support a clinical community-focused program, The Autism Cares Act ensures this knowledge reaches all families through improved services, personalized intervention, and toolkits for autistic-specific challenges. This work has formed a critical foundation for moving forward. With reauthorization of the Autism Cares Act, we'll build on the progress made to close a significant gap for too many autistic people, ensure that every autistic person is able to reach their full potential. This includes investing in more research, focus on the daily life challenges of autistic adults, improving our understanding of autism and aging, such as the elevated risk for dementia and heart disease. It includes furthering research on how to reduce disparity in autism diagnosis and access to services. It includes ensuring that we are researching how to best support autistic people who are non-speaking or may need additional communication support. It includes investing in more research in how we can best meet the healthcare and safety needs of autistic people who are required 24-hour care, may struggle with harmful behaviors, and so much more. I will just close with this thought. With the increased autism prevalence rate, coupled with much greater acceptance of autism in our nation, it's likely each of you knows someone, a loved one, friend, neighbor, a constituent who's on the autism spectrum. I would guess that if each of you turn to speak with a colleague next to you, that the individual experience, the strength and challenges of an autistic person you're thinking of will be very different. As you move towards reauthorizing, enhancing the Autism Cares Act, I urge you to keep these individuals in mind. This work to ensure that they, along with millions of others on the spectrum, live the best life possible. Thank you again for this opportunity to testify. I look forward to your questions.
Thank you for your opening statement, and Mr. Feist, you're recognized for 5 minutes for your opening statement.
Hello, my name is Corey Feist. I'm the CEO and co-founder of the Dr. Lorna Breen Heroes Foundation. It's great to see you all again. Our mission is to reduce burnout of health professionals and safeguard their well-being and job satisfaction. Thank you to the chair and ranking member for the opportunity to address you all today, and for this committee's work in the last Congress to pass the Dr. Lorna Breen Healthcare Provider Protection Act. While there has been much progress made since I sat in this seat just a couple years ago, there are still millions of health workers who are tirelessly working to save lives, yet often at great personal risk because of how the healthcare system operates. I stand before you as the voice of 22 million health workers urging you to reauthorize the Dr. Lorna Breen Healthcare Provider Protection Act, H.R. 7153. This legislation aims to combat suicide, burnout, and the mental health challenges among health workers. I want to extend a special thanks to Representatives Kiggins, Buddy Carter, Debbie Dingell, and Susan Wild, as well as Senators Tim Kaine and Todd Young for their commitment to championing this cause. Addressing burnout necessitates a dual approach: individual support and systemic change. Individual support programs act like pressure on a bleeding wound, that wound of burnout, essential for immediate relief. However, true healing requires addressing the root cause of the bleeding, the environment of care. Systemic efforts such as reducing administrative burdens on health workers are imperative to long-term relief. In 2021, I shared the tragic story of my sister-in-law, Dr. Lorna Breen, the inspiration behind our foundation. Today, rather than sharing Lorna's story, I want to share stories of those who have reached out to us in response. In just the last 2 weeks since the introduction of H.R. 7153, thousands of health workers have written you all as representatives, sharing poignant stories. Retired nurse Tammy Brown shared the heartbreaking loss of her husband, Mo, an orthopedic surgeon, to suicide, underscoring the urgency of ending the stigma around seeking mental health. Tammy's message to you: this loss is enormous, tragic, and could have been prevented if he wouldn't have feared punishment and stigma of needing help at a very stressful time in his life. This should never happen again. A veteran nurse highlighted the importance of accessible counseling, emphasizing its positive impact on both professional and personal life. These stories illustrate the critical need for comprehensive mental health support in the healthcare sector. One particularly tragic story is that of Tristan Kate Smith, a 28-year-old nurse who died by suicide. Before her death, Tristan left a message, which said, "Ever since I was young, I expressed an interest in healthcare and becoming a nurse. So I began my study. I gave my heart, my body, and my mind to you. I no longer feel like you care about me or the people you say you serve. When we dare to think we are finally getting the love and support we deserve, we get a pizza party and free pens for the healthcare heroes. I so desperately want to continue to help people, but I cannot stay in this abusive relationship any longer. Each day you ask me to do more with less. Tristan's experience is not isolated. In fact, female nurses are 8.5 times more likely to die by suicide than the general female population. In October of 2023, the CDC issued their Vital Signs report, which underlines the mental health crisis within the healthcare workforce, with significant increases over the past few years in burnout, intent to leave, and harassment. Further alarming statistics indicate that over the past few years, there has been a significant exodus from the nursing workforce, with nearly 900,000 registered nurses intending to leave by 2027. Coupled with the impending surge in the elderly population by almost 50% in the next 10 years, this amplifies the urgency around this impending healthcare crisis. Who is going to take care of all of us? The Dr. Lorna Breen Healthcare Provider Protection Act is a vital step and has catalyzed the change in supporting and protecting the healthcare workforce. $103 million in funding has supported 44 health organizations in implementing this work. However, that represents less than 1% of health workers and 1% of the hospitals in this country. Additional resources funded the Impact Wellbeing Campaign, which provides health leaders evidence-informed solutions to reduce burnout. Hospital leaders need guidance in doing this work. This Act's reauthorization focuses on reducing administrative burdens, recognizing the need to address this burnout and this bleed at its root cause. This is not merely policy, it is vital to our healthcare delivery supply chain. Thank you for your time, consideration, and support.
Thank you for your opening statement. Thank you for all your work. Dr. Pike, you're recognized for 5 minutes for opening statement.
Chairs McMorris, Rogers, and Guthrie, ranking members Pallone and Eshoo, and members of the subcommittee. My name is Joanne Pike, and I am the president and CEO of the Alzheimer's Association and CEO of the Alzheimer's Impact Movement. Thank you for the opportunity to testify today to discuss 4 key laws that have been instrumental in prioritizing our nation's response to the growing impact of Alzheimer's on over 6 million Americans and their 11 million caregivers. The association and AIM are proud to support the NAPA Reauthorization Act, the Alzheimer's Accountability and Investment Act, the BOLD Reauthorization Act, and the Lifespan Respite Care Reauthorization Act. We are grateful to the subcommittee and the champions leading these bipartisan bills for their timely consideration. Congress must reauthorize these laws now to ensure our country continues to advance policies that improve the lives of people living with dementia and their caregivers. I also want to take an opportunity to thank all of the advocates behind me in the room today, and those watching nationwide, especially those living with dementia or mild cognitive impairment. By sharing your stories, by advocating in your communities, you're giving everyone living with dementia the courage to do the same. You inspire all that we do to achieve our vision of a world without Alzheimer's and all other dementia. As too many of us in this room know, Alzheimer's is a progressive, fatal brain disease. We need to continue our commitment to think boldly, dream bigger, and step up to deliver a future in which no one is left behind. Not in prevention or diagnosis, or treatment, or support, or care, or cures. In 2011, Congress passed the Bipartisan National Alzheimer's Project Act, also known as NAPA, resulting in the landmark National Plan to address Alzheimer's disease. The National Plan continues to drive meaningful change, creating and implementing strategies to address Alzheimer's and other dementia. NAPA also led the creation of the Advisory Council on Alzheimer's Research, Care, and Services, which I am currently serving. Simply put, the landscape has changed as a result. For the first time, people living in the early stages of Alzheimer's have FDA-approved treatments that slow disease progression. In fact, more treatments and diagnostics are in the pipeline than ever before. While the national plan has clearly driven enormous progress, we still have much work to do. The bipartisan NAPA Reauthorization Act would extend this important work through 2035 and modernize the law to reflect strides the field has made in understanding the disease, such as including a new focus on healthy aging and reducing risk factors. Reauthorizing NAPA ensures the continuity of vital initiatives fostering advancements in understanding treatment and care for individuals living with Alzheimer's disease and other dementia. The 2015 Alzheimer's Accountability Act complements NAPA's efforts by ensuring that NIH receives the funding and resources essential to making meaningful research progress in the fight against Alzheimer's. The law requires the NIH to annually submit a bypass budget, an estimate of the investment needed to reach the research goals of the national plan. This annual bypass budget has been a crucial blueprint for Congress, enabling historic increases in Alzheimer's research, investments, and leading to a more than 7-fold increase in Alzheimer's funding at NIH over the past decade. These increases have enabled groundbreaking advancements, including improved blood biomarker test accuracy. Blood biomarker tests will revolutionize the detection of Alzheimer's, allowing for earlier, more accessible, and accurate diagnoses, and the ability to track how people are responding to treatment. This progress must continue. Reauthorizing this law through the Bipartisan Alzheimer's Accountability and Investment Act will reinforce Congress's commitment to prioritizing the resources needed to address the challenges posed by Alzheimer's and other dementia. The bill would ensure NIH continues to submit an Alzheimer's annual bypass budget to Congress and the President through 2035. The Alzheimer's community is also grateful to Chairman Brett Guthrie and Congressman Paul Tonko for their leadership on the 2018 Building Our Largest Dementia Infrastructure for Alzheimer's Act, also known as the BOLD Act, and recent efforts to reauthorize this important law. The BOLD Act has enabled communities nationwide to implement public health strategies that promote brain health, address dementia, and support people living with dementia and their caregivers. The BOLD Act is set to expire this year. The Bipartisan BOLD Reauthorization Act of 2024 would ensure this important work continues in communities across the country. It is vital that Congress passes this bill. Doing so will help further population-level improvements, achieve higher quality of life for those living with the disease and their caregivers, and reduce associated costs. Finally, we thank the subcommittee for considering ways to help support caregivers of people living with chronic conditions such as Alzheimer's and other dementia through the Lifespan Respite Care Program, which continues to play a crucial role in helping support caregivers and enhancing the overall quality of life for people with chronic conditions or disabilities. Reauthorizing this program is essential for sustaining a supportive infrastructure to help alleviate caregiver stress and enhance care quality for people with chronic conditions. The swift enactment of these 4 bipartisan bills will enable further strides in understanding, treating, and ultimately preventing Alzheimer's and other dementia. We have so much to be excited about and hopeful about. We know, many of us personally, how important these advancements are for real people, our families, our friends, and our neighbors. I appreciate the opportunity to testify before you today and look forward to answering any questions you may have.
Hey, thank you for your opening statement and appreciate it. Dr. Tomaselli, you're now recognized for 5 minutes for opening statement.
Thank you. Chairman Guthrie, Ranking Member Eshoo, and members of the Health Subcommittee of the Committee on Energy and Commerce, thank you for this opportunity to testify on behalf of the American Heart Association, now celebrating its centennial year. My name is Gordon Tomaselli, and I'm a cardiologist and an expert in the field of sudden cardiac death. You have my CV, but briefly, I am the Emeritus Dean of the Albert Einstein College of Medicine and a professor of medicine at Einstein and at the Johns Hopkins School of Medicine. I'm a former president of the AHA, and I've been proudly among the organization's 40 million supporters for more than 30 years. Although my interest in cardiovascular disease and science was codified early in my training, a personal connection to that disease galvanized my clinical track. At the age of 49, my mother, who was suffering from cardiomyopathy, experienced a cardiac arrest. She was resuscitated, but continued to suffer from life-limiting heart failure. She underwent cardiac transplantation, which allowed her to enjoy nearly 2 decades of full life. Today, I'm pleased to testify about the ways in which your bills under consideration, namely the Cardiomyopathy Health Education Awareness Research and Training in the Schools Act of 2023, or the HEARTS Act, and the Congenital Heart Futures Reauthorization Act of 2024 would improve the health and safety of students afflicted with congenital heart disease. First, a story as a bit of backdrop for my remarks today, and I refer you to the 2 photographs in front of me. On what started as a regular day, Megan Etheridge and her husband were working from home, and their 2 kids were at school. Megan's phone rang, and she was told that her son Colin had fainted after running up the stairs at his middle school. That's pretty concerning, but the school said they thought he'd be okay. A few minutes later, the school called again. Things were not okay. Fortunately, this story has a happy ending, but Colin had fainted and had a cardiac arrest and wasn't breathing. Colin's school had gone above and beyond in school safety. The school had created a cardiac emergency response plan, an easily accessible automatic external defibrillator, or AED, and staff who are trained and ready to perform CPR and use the AED. Today, Colin is doing well, and his parents have gotten the opportunity to see him grow up. The American Heart Association thanks Ranking Member Frank Pallone Jr. for his work to champion the HEARTS Act, which will improve the safety of our schools and ensure students, faculty, staff, and others are prepared to respond quickly and effectively to a cardiac arrest in classrooms and on playing fields. The legislation requires HHS to coordinate with CDC to develop educational materials and resources on cardiomyopathy, a leading cause of disability and sudden death among young people. It also calls for guidelines regarding the placement of AEDs in school, the establishment of the cardiac arrest emergency plans, as well as information on CPR training. In addition to the HEARTS Act, the American Heart Association strongly urges Congress to pass the bipartisan Access to AEDs Act, which would authorize critical resources needed to implement many of these life-saving policies. Today, more than 350,000 individuals in the United States experience an out-of-hospital cardiac arrest, with only 1 in 10 surviving. Up to 23,000 of these are lethal events in children under the age of 18, many of them with cardiomyopathy or other congenital heart diseases, making these preventable tragedies the leading cause of death for high school athletes. For every minute without CPR, a cardiac arrest patient's chances of survival drops by 10%. The average arrival time of emergency medical services is 7 minutes. Lay responders are often truly the first responders, and they need more CPR training and better access to AEDs to save lives. Evidence shows that in cardiac arrest emergencies where people are close by, AEDs used beforehand, before EMS arrival, patients survive meaningfully 2.5 times more likely than those who did not receive the same care prior to EMS arrival. Despite AEDs being proven as life-saving devices, only 20 states currently require AEDs to be placed in schools. Even fewer states have programs to help schools purchase these devices. The HEARTS Act, together with the Access to AEDs Act, would fill these gaps. Ideally, all school staff should be trained in first aid, CPR, and AED use. This February, as we observe we observe Heart Month, the American Heart Association is working to turn a nation of bystanders into a nation of lifesavers, so that everyone, everywhere, is prepared and empowered to become a vital link in the chain of survival and provide CPR and AED. We hope that you will join this nation of lifesavers as well as your constituents. The American Heart Association is also pleased to support the Congenital Heart Futures Reauthorization Act, and we thank Congressman Gus Bilirakis for sponsoring this bill. It's a crucial piece of bipartisan legislation that addresses the pressing need for continued funding and research into congenital heart disease. This legislation builds upon the initial Congenital Heart Disease Future Act of 2010, a pioneering effort to allocate resources specifically for congenital heart disease research and data collection. This Reauthorization Act emphasizes the need to advance congenital heart disease research and awareness by further enhancing biomedical research at NIH, expanding public health research and data collection at CDC, and raising the public awareness of congenital heart disease throughout the patient's lifespan. I thank you for the opportunity to offer my perspective today and for your continued leadership to improve cardiovascular health and wellness. The written and oral statements reflect my views and that of the American Heart Association, and not necessarily those of Johns Hopkins University or the Albert Einstein College of Medicine. I look forward to your questions.
Thank you. Thank you for your opening statement. The chair will now recognize Ms. Whitten for 5 minutes for your opening statement.
Chairman Guthrie, Ranking Member Eshoo, Chairwoman Rogers, and members of the committee, thank you for the opportunity to testify at today's hearing. My name is Michelle C. Whitten, and I am the co-founder, president, and CEO of the Global Down Syndrome Foundation and the mother of 2, including Sophia, a vivacious 20-year-old sophomore at Regis University who happens to have Down syndrome. People with Down syndrome are born with 3 copies of chromosome 21 instead of 2. This extra chromosome results in a radically different disease profile whereby people with Down syndrome are highly predisposed to certain diseases and highly protected from others. For example, people with Down syndrome are the largest population with a genetic predisposition to Alzheimer's disease. By studying people with Down syndrome, we can help our loved ones with the condition and potentially help millions of others who suffer from Alzheimer's. Half or more of people with Down syndrome are born with congenital heart defects, are predisposed to autoimmune disorders and to certain blood cancers. Conversely, they are highly protected from developing solid tumor cancers such as breast cancer or prostate cancer. In the 1980s, the average lifespan of a person with Down syndrome was 28, and today it is 60. But that's still 16 years behind the general population. And unfortunately, for those in rural areas and for Black people with Down syndrome, preliminary studies indicate a substantially shorter lifespan. Down syndrome is a complex condition, and research needs that involve almost every one of NIH's 27 institutes and centers. Fortunately, our bipartisan congressional champions, Chair Rogers and Representatives Rosa DeLaura and Tom Cole, recognize the impact Down syndrome research could have on millions of Americans. They increased federal funding and urged NIH to initiate a trans-NIH or NIH-wide effort called INCLUDE, Investigation of Co-occurring Conditions Across the Lifespan to Understand Down Syndrome. Global is forever grateful to these fierce advocates. There's no doubt that the creation of INCLUDE is increasing lifespan and improving health outcomes in those with Down syndrome. Since FY18, INCLUDE has provided 556 unique awards from 18 different NIH institutes and 11 institutes participating in Down syndrome research for the very first time. Just consider some of the progress. Because of INCLUDE, we now have 12 Down syndrome clinical trials, but more is needed. Because of INCLUDE, my daughter and the 450,000 people with Down syndrome in the US are starting to have the opportunity to participate in Alzheimer's research. And INCLUDE has established a groundbreaking data coordinating center led by Dr. Espinosa, where all scientists have open access to research across all the NIH institutes. Global has long advocated for Down syndrome centers, and recently INCLUDE has put out a request for proposal for the very exciting and transformative Down syndrome clinical cohort coordinating centers, DS4C, and centralized biobank. The Deandra Dixon INCLUDE Project Act of 2024 to authorize a trans-NIH model for Down syndrome research would ensure that multiple NIH institutes will collaborate and coordinate research planning, funding, and sharing and disseminating of research results. Global is so moved that our sponsors are paying tribute to our beloved Global Ambassador and Quincy Jones Exceptional Advocacy Awardee Deandra Dixon, an accomplished self-advocate who tragically passed away in 2020 at the age of 36. This legislation honors her and all individuals with Down syndrome. I also want to express Global support for the Charlotte Woodward Organ Transplant Discrimination Prevention Act, which would prohibit healthcare providers and matching entities from discriminating against patients who need organ transplants solely based on disability. This bill highlights the importance of and need for auxiliary aids and services, a support system to assist with postoperative care, and the need for reasonable modifications to policies and procedures to make organ transplant systems and facilities more accessible to those with disabilities. In addition, we want to share our support and appreciation for Chair Rogers' bill, the Protecting Healthcare for All Patients Act, which bans all federal health programs from using discriminatory measures such as the Quality Adjusted Life GEARS to deny or restrict medical coverage for patients with Down syndrome or other conditions. It is important that this applies to all government health programs and not just Medicare. While there is still much work to be done for us to close the gap on lifespan and health outcomes for those with Down syndrome and other intellectual disabilities, the momentum continues to build. For people with Down syndrome, we're entering a new era where they're respected citizens. Authorizing the INCLUDE project ensures our dedicated researchers can continue to work to reduce health disparities, elongate life, and improve health outcomes not only for people with Down syndrome, but for everyone. Thank you again for the opportunity to testify today, and I look forward to your questions.
Thank you for your testimony. The chair will now recognize Mr. Strozik for 5 minutes for questions.
Good morning, Chair Guthrie, Ranking Member Eshoo, members of the House Energy Commerce Subcommittee on Health, and the full committee Chair McMorris Rogers and Ranking Member Plone. I'm incredibly honored to be here today to provide testimony on several legislative proposals on today's agenda that speak to the importance of emergency medical services across our healthcare system. My name is Randy Strozik. I have the great honor of being the president of the American Ambulance Association, a trade association represents organizations providing both 911 service and vital ground interfacility transports across our nation. In addition, my day job is I am the Senior Vice President of Operations at American Medical Response and Global Medical Response, the largest provider of ground ambulance services in the United States. I've also been in EMS for 40 years now, and today, listening to the various testimonies, each of the members or representatives here today touched my life and members of our community who provide EMS. The American Ambulance Association and members of all EMS providers, public or private, serve as the healthcare safety net for our communities and play a critical and unique national role in responding to hurricanes, floods, fires, and other disaster situations. EMS providers respond 24 hours a day, 7 days a week for those in need. And put simply, we are there for all Americans when they call for help every day. In the interest of time today, I will be speaking on 4 bills and representing those. Each of these bills have strong support from national organizations that are behind them. And for principle of time, I'll avoid going through the long list. But one that is really critically important to America today is House Resolution 4646, the Siren Reauthorization Act. Across America, much of EMS is provided to rural America by volunteer and not-for-profit and public entities. Funding for these entities is always difficult and a challenge, either because of limited tax bases or small communities. But as we found during COVID, these programs and these systems were a critical part of delivery of health care. At 2 o'clock in the morning in the middle of rural America, when you needed help and dialed 911, they came and they provided service. In addition, new challenges arose for these various rural services where they had to provide transportation across to larger tertiary facilities. Many of these services are provided by volunteers. In addition, they are now being impacted by both the epidemic of opioids and increased levels of mental health care, thus requiring additional levels of training. We call on the support for this, and we are very pleased to thank Representative David Joyce and Debbie Dingell for bringing this bill forward and the importance of it. Next, one that, as all of us as parents and grandparents are very supportive of, is the Emergency Medical Services for Children Reauthorization Act, House Resolution 6960. In my 40 years as an EMS provider, early days as a paramedic, we've seen the change in healthcare for children from treating them as small adults to truly what they are. They're a unique group of citizens and caregivers that need a special level of education and opportunity to receive the proper care. We have trained our EMTs and paramedics to have new skills to understanding the level of care, recognize not only the levels of injury and need for tertiary care, but we brought that level of training forward to rural hospitals and then to make that determination to take that forward to community and large hospitals as the many children's hospitals. This has been incredibly important, and we've seen a tremendous increase in outcome, in efficacy, level of care, and positive outcomes. As a grandparent, I can't support this more. Great thanks to Representatives Carter, Castor, John Joyce, and my representative, Kim Schreier, for introducing this act. My third today is the reauthorization of the Traumatic Brain Injury Program, House Resolution 7208. We have learned through time that the treatment, identification, and follow-up of treatment of traumatic brain injury is a critical factor in the return to a quality of life by patients who have suffered these injuries. Research and education has taught us how to better protect our student athletes, how to protect citizens post-accident, and use this as a means of bringing not only what we've learned from our military experiences, but to bring care and forward. And continued research in the issue of treatment of traumatic brain injury will be critical. There's an interesting analogy we may pull here, is that motorsports has become an important part of training and education. NASCAR, IndyCar, IMSA are all involved very distinctly in finding and identifying means of taking care of this. And finally, I want to speak to the amendment of public health service authorization for certain poison control centers. As a parent, I totally understand the importance of this. These centers across America have become a critical part of our system of providing care to citizens. And as a growth and exposure to opioids and so forth, these centers are a treasure to all of us who provide care and to parents every day who need to call for this help. I've appreciated my time today, and I'll finish very quickly by saying we will be coming forward to the committee to talk future on funding for EMS across our country, which is at risk as costs have risen, and then finally to talk about how we are going to acquire and bring on new members to provide EMS for our country for our staffing and workforce issues. I appreciate your time, and I am 56 seconds over.
Well, thank you for your testimony, and Dr. Annunziata, you're now recognized for 5 minutes.
Thank you. Good morning, Chairman Guthrie, Ranking Member Issue, and members of the subcommittee. I'm Christina Annunziata, Senior Vice President of Extramural Discovery Science for the American Cancer Society. And I'm pleased to be here today to express strong support of the American Cancer Society and our affiliate, the American Cancer Society Cancer Action Network, for the Screens for Cancer Act and the Women Lung Cancer Research and Preventive Services Act. Passage of these two bills could have a critical impact on reducing the burden of cancer for women in our country. Breast and lung cancer are the leading causes of cancer incidence and mortality in women. In 2024, 970,000 women will hear the word, "You have cancer," including 310,000 new cases of breast cancer, 111,000 new cases of lung cancer, and 13,000 new cases of cervical cancer among women. Also in 2024, 288,000 women will lose their lives to cancer, including 42,000 deaths from breast cancer, 59,000 deaths from lung cancer, and 4,300 deaths from cervical cancer in women. We also know that cancer does not affect everyone equally, and there are differences among women themselves and between women and men. For example, despite historically lower smoking rates than men, women still make up half of all lung cancer cases and deaths. Compared to men, women have slightly higher proportion of lung cancers that are not attributed to factors like smoking. And while lung cancer is higher for men overall, in the younger population of ages 35 to 54, the cancer incidence is higher in these younger women than for their male counterparts. And this is also a fact not fully explained by smoking status. With respect to breast cancer, the death rate for Black women is 40% higher than for white women, despite lower breast cancer incidence rates in Black women. Similar disparities occur in cervical cancer, where the death rate for Black women and Native American women are 65% higher than for white women. And according to the recently released American Cancer Society Facts and Figures report, cervical cancer is actually increasing in incidence in women ages 30 to 44. Women who are underinsured or uninsured are less likely to get the recommended screening for breast and cervical cancer, resulting in a greater risk at being diagnosed at later, more advanced stages of disease than women who are insured. And the more advanced stages of cancer require more intense treatments and carry a higher risk of death, from the cancer. These two pieces of legislation can change those facts and reduce the number of women who suffer and die from cancer in the United States. The Screens for Cancer Act reauthorizes the National Breast and Cervical Cancer Early Detection Program through 2028 and gives greater flexibility to grantees to implement innovative, evidence-based early detection and screening interventions to reach women eligible for the program. The American Cancer Society Cancer Action Network has long advocated for this screening program because it is the gold standard for providing breast and cervical cancer screening, diagnostic tests, treatment referral services to women who have limited incomes and are uninsured or underinsured. Funding for the program helps address inequities in breast and cervical cancer screening and diagnosis, especially for people who are geographically isolated and for those who belong to racial and ethnic groups that are disproportionately impacted by these cancers. The program has been highly successful, having provided 15 million screening exams to more than 6 million eligible people and detecting more than 75,000 breast cancers, 24,000 pre-malignant breast lesions, as well as 5,000 cervical cancers, and 235,000 pre-malignant cervical lesions since its inception in 1991. Simply put, without this program, more women will be diagnosed with breast and cervical cancer at later stages, leading to unnecessary suffering and premature death. Passage of the Screens for Cancer Act is necessary to ensure continued and timely access to vital breast and cervical cancer screenings, which help reduce the unequal cancer burden. In my role at the American Cancer Society, I lead an interdisciplinary team of scientists to identify and fund the most innovative and promising research to end cancer as we know it for everyone. The Women and Lung Cancer Research and Prevention Services Act calls for the same scientific process through an interagency collaboration to review and identify opportunities for research on women with lung cancer, including evaluating environmental and genomic factors contributing to lung cancer in women, and advancing new technologies for prevention, risk assessment, diagnosis, and treatment. This type of cutting-edge research, tied with evidence-based public education campaigns, can truly turn the tide on women in lung cancer. So thank you for this opportunity to testify today and express our strong support for the Screens for Cancer Act and the Women and Lung Cancer Research and Preventive Services Act. We urge you both to pass these bills as quickly as possible to end cancer as we know it for everyone. Thank you.
Thank you, Dr. Zanata. Thank you for your opening statement, and now that concludes all of our opening statements. We'll go to members' questions, and so I will begin by recognizing myself for 5 minutes for questions. And Dr. Pike, I'm focused on the BOLD Infrastructure for Alzheimer's Act before, and focused on it because I saw my mother-in-law care for her father, and over the last couple of years, and or a little longer, seeing my wife and her siblings care for her and I think that was the biggest burden when she realized what was happening to her, that she knew what she had to do for her father, what it was going to put on her family. So it's important that we address it in every way possible, and she passed away in October. But in reauthorizing the BOLD Infrastructure for Alzheimer's Act for another 5 years, this will ensure our constituents living with the disease, including 75,000 Kentuckians, can continue to benefit from initiatives under BOLD that promote brain health, improve early detection and diagnosis, and support people living with dementia. So Dr. Pike, could you describe some impactful real-world examples that you've seen over the last 5 years since BOLD was in action? And also, would you suggest any educational resources that you think may be helpful to caregivers, providers, and patients that the reauthorization bill can work toward providing?
Thank you for your leadership, Chairman Guthrie, in introducing the original BOLD Act and its much-needed reauthorization as well. The BOLD Act has proven to be successful as a resource in implementing effective Alzheimer's public health strategies in communities nationwide. And since 2018, the CDC has established 3 Alzheimer's public health centers of excellence and has made 66 awards to 45 state, local, and tribal public health departments, including in your state of Kentucky. In Kentucky, for example, BOLD funding is increasing the state's capacity to operationalize its Kentucky State Alzheimer's Plan. Kentucky's initial investment in Alzheimer's disease and other dementia led to the creation of a full-time state agency. The Dementia Services Coordinator staff position is also a catalyst that came from your BOLD Public Health Award. And in September 2023, the Kentucky Department of Public Health was awarded funding to develop strategic statewide strategies to address Alzheimer's, which is already allowing the state to support the work of Kentucky's Office of Dementia Services. There are education programs, though, that come along with that focus on risk reduction, early detection, and also healthcare system education as well. So are things that we can introduce long-term, certainly, but things that we know have been successful to move the needle on the public health strategy for Alzheimer's.
Thank you for that answer. Now, Ms. Whitten, would you discuss the various co-occurring conditions individuals with Down syndrome may have and why it's critical to ensure that those with Down syndrome have equal access to approved therapies and treatments?
Yes, absolutely. You know, we've talked about Alzheimer's. You know, unfortunately, 100% of people with Down syndrome will have the plaques and tangles associated with Alzheimer's, and an estimated 70% will go on to get the dementia. This is a really important population. Also cancer, there's certain kinds of leukemia that are really up in people with Down syndrome. Autoimmune disorders, really high up, well over 50%. And then even autism. You know, my colleague here from Autism Speaks, the recent American Academy of Pediatrics guideline shows that it's not what it thought it was in 2011, maybe 2 or 3%. It could be as much as 30 or more % of people with Down syndrome also have autism. They also are protected from certain kinds of heart attack, certain kinds of stroke, and as the chairwoman said, It's extraordinarily rare for a person with Down syndrome to suffer from a solid tumor. So this radically different disease spectrum really requires a NIH-wide approach to research. In the past, they've done great work at the NICHD, but we can't just be siloed in a child health and human services area. So this trans-NIH approach really is not only going to help 9 million people with Down syndrome worldwide, but it stands to really help those people suffering from diseases that have the co-occurring or where they're protected from. I think it's important to note that where they're up or down in diseases, those diseases represent 60% of American deaths. So these are major diseases. So we're very excited and so grateful for all of your support for this important bill.
Thank you. And I have just a few seconds. I don't have enough for another question, but in cardiac arrest, just an example of why this is so important. I was talking to my wife on the phone one time. In Kentucky, sometimes storms just pop up. It doesn't even look like you could have one, but it happens. And my wife, I heard the thunder, and she goes, wow, that was really close. Turned out a kid about 3 houses down from us had been struck by lightning. And which turns out to be a good story, given that, is that the person he was with was another young teenager who knew CPR from Boy Scouts. A guy around the corner was an ambulance. A guy named Gary Madison, who's our legendary in paramedics, just around the corner, heard it on his radio, and he immediately had a teenager doing CPR, then a professional doing CPR, from life flighted to Vanderbilt, and is now living. But if he hadn't have had that kind of care, and I'm out of time, but hadn't had that kind of care, so that's what's important, that we try to get his care as quickly as possible. And my time's expired. I'll yield back and recognize the gentlelady, the ranking member from California.
We hope for in the American Heart Association that something like that doesn't turn into a tragedy.
Yep, immediate response is important. So, ranking member?
Thank you, Mr. Chairman. I want to thank each of the witnesses. You've given really such important testimony. And to all of the advocates in the in our hearing room today, you need to know that you are the oxygen of all of these efforts. Before I came to Congress, I thought that Congress was a proactive institution. And I don't know what got into me, but I got here and quickly realized it's a reactive institution, reacts to the voices of people from across the country. So when I say that you are the oxygen of all of these efforts, you move the needle every day, every month, every year in all of these efforts. And we're all really very, very grateful to you. And I'm always mindful that legislation doesn't move without you. So bravo to each one of you. Mr. Feist, it's great to see you again. You were here in 2021. You described that your late sister-in-law, Dr. Lorna Breen, was afraid because she was convinced she'd lose her medical license if she asked for help, a fear that ultimately contributed to her death. Your testimony, really outlined where we are in the country today. We have 6,120 hospitals in the country, but only like 1%, the needle is moved, like 1%. I'm grateful for the 1%, but at this rate, the issue is not going to be addressed. I don't know the following, and I'd like to ask you if you do. Do hospitals cover their doctors' insurance, or is it up to the doctors to determine on their own what they buy?
Which type of insurance are you speaking of?
Well, health insurance.
Their health insurance, okay. I didn't know if you meant malpractice insurance.
No.
So lots of insurance out there. So first of all.
That's a whole nother issue.
It is. By the way, I have Jennifer here, Lorna's little sister. My wife is also here today with me. I didn't acknowledge her in my remarks, but she's here.
Thank you for being here. Thank you.
Thank you so much for asking that. It's really interesting. So the insurance that is covered by physicians, if they are for their care, personal care, is their employer. So if they're employed by a hospital system, which a huge section of our physicians in this country are,
That's why I'm asking the question.
then yes, they do not have a choice. They are given the insurance. You're probably getting at what their network of providers are.
Well, I'd like to know if in fact the hospitals, the doctors are insured through their employer, the hospital. Is mental health coverage part of it?
It is, and importantly, what we
I don't know how far we get with administrative issues. I think that their insurance policy should cover mental health issues, and that it be private and not subject to the general gossip of the hospital that Dr. Smith is receiving mental health counseling.
That's exactly right. So what you're getting at is actually where they need to get care. Now, their employer defines who provides them the care. And in most cases, if you're a hospital system providing insurance to your employees, you tend to not want to broaden the network of options because you're kind of paying your competitor to take care of your employees, if you will. In the mental health space, what you're speaking to is exactly what we need to do. We need to broaden the networks to make sure that physicians can seek care
Well, let me ask
outside
you
of the
this.
hospital.
Don't you think in a reauthorization that this issue needs to be addressed?
Yes, yes. So I mean, if I may, just for a second, what you're talking about is allowing the networks for the physicians to be able to access outside of their institutions because of their concern around confidentiality, and that is.
Well, I think
that is
if
a
it's
serious issue.
confidential, it really doesn't matter whether it's inside the institution they're working at or outside. Or do you think I'm wrong on that?
If you speak to the widow of Scott Jolly from Utah, his only network option was in his hospital system, and he was so burdened by the stigma of being treated by his colleagues, he died by suicide.
Well, my time has expired.
you.
Thank you to each one of you.
Thank you. The ranking member yields back, and the chair will recognize the chair of the full committee, Chair Rogers, for 5 minutes for questions.
Thank you. I too want to thank everyone for being here, all the advocates, and those that have testified. We are covering a lot of ground today. I wanted to start with Mr. Strozik, and recognizing you're from Washington State and a WSU alum, I wanted to say go Cougs, but before I get to my question, I also wanted to quickly take some time to congratulate Mr. Jacob Ambach from Spokane, Washington, for being recognized as one of this year's Distinguished Stars of Life honorees by your organization, the American Ambulance Association. Mr. Ambach saved the lives of 5 patients who suffered from cardiac arrest last year, and if it had not been for his work, the patients may not have survived. So we greatly appreciate his service. Now, Mr. Strozik, you mentioned in your written testimony that EMTs and paramedics have experienced increasing challenges when responding to mental health and substance use disorder-related calls. Would you just speak briefly about some of the challenges and how the Siren Reauthorization Act would help improve patient care?
Thank you, and I greatly appreciate the words "Go Cougs." So that's made my day. Chairwoman, across the country as the epidemic has occurred with opioids, which we can always speak in terms of major cities, be it Seattle, be it Spokane, be it Portland, where we've seen this across the country. As this has spread into rural America, it's an environment that is foreign. It's hard to imagine that your neighbor could be overdosed on fentanyl and you're having to deal with this. In addition, mental health illness, as it has progressed and been recognized across the United States, requires an additional level of training and skill to handle so that the patient is taken to the appropriate level of care at the appropriate time. The difficulty as rural America has seen the closure of hospitals and clinical facilities, the ability to get these patients to that level of care has challenged these systems.
Right.
As an
Okay.
example, in your district, when they leave
you.
Washtucknett to go to
Yes.
Spokane, it's difficult.
Thank you. Thank you very much. Ms. Witten, you know, for all the advocates, I'll just, we have a son now. with Down syndrome. He's 16 years old, and I will always remember when Michelle brought in Sophia and, to introduce me to her daughter early on when he was first born, and just appreciate your advocacy for many years. I'm grateful for those who went before me, as all advocates are. You know, we're all only one diagnosis or car accident away from being in the same position. And so it really makes a difference, and just so grateful to you, Ms. Whitten, and all that you've done, your passionate advocacy for individuals with Down syndrome. You outlined some of the incredible accomplishments of Include and what has happened at NIH since Cole was first born, and as we've come a long way. And it includes research at WSU now, examining dementia in individuals with Down syndrome, related work to develop low-cost screenings that detect dementia at early stages. This is certainly going to help individuals with Down syndrome get treatment sooner. The Deandra Dixon Include Project Act is going to strengthen all of these activities and initiatives for many years to come. And I wanted to ask if you would speak to just what else NIH could be doing to further improve Include's mission and purpose, and also support the Down syndrome community.
Thank you so much. And of course, your leadership has been profound, right? When my daughter was born, the funding for Down syndrome research was $16 million. That was 20 years ago. And for 20 years, it kind of floundered between 16 and 22 million. So again, the leading cause of developmental delay, one of the least funded genetic conditions, all sorts of reasons why that's wrong. I would say, I also want to call out Mr. Frank Stevens, who's behind me, who has Down syndrome, who was at the seminal hearing that Congresswoman Rosa DeLauro and Congressman Cole had, and from which Include sprung, right? And I think Frank's testimony that, he basically said, if you take away one thing, know this: I'm a man with Down syndrome and my life is worth living. And the reason I bring that up is because, we're humans, we're people, we're equal. We might be different, but we're equal, and we deserve a lot better. And in terms of what NIH could be doing, I think they've got a beautiful structure through Include on focusing on clinical trials. We're still prevented from participating in many, many clinical trials. And so NIH, working with FDA, working with advocacy organizations, we need more people in clinical trials, and we need more clinical trials for people with Down syndrome, right? For example, our big discovery that Down syndrome is an immune system disorder, right? And that a whole class of JAK inhibitor drugs can actually stabilize their immune system is huge, but it's not something you would do for a typical person or a person without Down syndrome. So that study, and then of course, Deandra Dixon, she was a role model, not just for people with Down syndrome, not just for people who are Black with Down syndrome, just for all people in the way she lived her life. And I think, this act really honors her, and it allows her to really advocate, from up above, and make sure that people with Down syndrome are getting the research that they deserve at the NIH and elsewise. The other thing that they can do is more RFAs like they're doing for transformational research, and then more medical research. We want it to be translational to people with Down syndrome in our lives.
Thank you. Thank you. Again, thank you for your advocacy. It's been because of Frank Stevens' testimony and so many others who have advocated that NIH has come a long way, the research, and is making a big difference in people's lives. And this is just one example, and much more to be done. Thank you, Mr. Chairman. I yield back.
Thank you. The chair yields back. And Frank, would you just stand so everybody recognize you here? Because I don't know if you're on the front row. Thank you. Thank you for your advocacy. The chair will now recognize the ranking member of the full committee, Mr. Pallone, for 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to start by talking about the HEARTS Act and go to Dr. Tomaselli. As I mentioned in my opening statement, I introduced the HEARTS Act after the tragic death of 2 young student athletes in New Jersey. and you're aware that cardiomyopathy conditions affect approximately 1 out of 500 people. Although cardiomyopathy is relatively rare, it's the leading cause of sudden cardiac death in children, which is very troubling to me. So a few questions, if you could. Dr. Tomaselli, what does the data show about the impact of having access to AED devices in schools administered by trained personnel?
Ranking Member Plum, thank you so much for the question. I would also add that there, in addition to cardiomyopathy, there are a variety of other conditions that are rare, but when added together, create a situation where, in fact, cardiac arrest is a palpable event in the community with often tragic outcomes. Now, what the data show is that in out-of-hospital cardiac arrest, the survival is really quite miserable. However, if we have AEDs and if we have responders who are nearby, the outcomes can be much improved. And a school is a community where, in fact, it's geographically constrained. There ought to be lots of, and if the AEDs Act is in place, there ought to be a number of first responders who are close by. And I suspect that the 2.5-fold increase in meaningful survival in standard out-of-hospital cardiac arrest would be even much better in schools if we had AEDs and we had providers in those locations to provide prompt treatment of sudden cardiac arrest.
Now, what about cardiac emergency response plans? Why is that important for schools to have, and can it make a difference between life and death?
Right. So, again, an important point. Again, we're talking about a timeline here that is in minutes, seconds to minutes, not hours or days. So a response that's prompt, a response that's coordinated is absolutely essential to improve outcomes. And this is done in a way most efficiently with a cardiac emergency response plan that includes a team that has leadership, that's drilled, that knows what to do, and in fact can overcome barriers that people feel when they approach a patient who has cardiac arrest. If you don't feel comfortable providing treatment, your reluctance will increase. Having a cardiac emergency response team and having training reduces that barrier to providing care. And I think, again, will help to provide prompt treatment for sudden cardiac arrest victims.
Then I wanted to ask you about raising awareness, because conditions like cardiomyopathy don't often present symptoms until it becomes advanced. So how do we help raise awareness about cardiomyopathy and disseminate information to schools or local health departments or health providers? How do we do that?
Yeah, so again, thank you. I think this is a problem, but also a mandate. And the mandate includes some component of actually the patient knowing what their own personal history is, what their family history is, and being prepared, because some of this is going to be proactive, that is understanding who in your community is at risk because they have congenital heart disease or they have cardiomyopathy, but also reactive, and again, links to the AED programs and cardiac emergency response, because even if you know beforehand, you don't know when a bad event may occur. So being prepared to respond quickly, but also understanding who's at risk in your community can allow us to better target where, in fact, defibrillators might be most necessary. A related question that often comes up in this context is that of screening athletes for sports participation. And in fact, there's an ongoing debate in the community about how this should be done. The American Heart Association believes in a 14-element screening protocol that includes personal history, family history, physical examination, and others, and measurement, for example, of blood pressures and cardiovascular examination that can identify people who might need further investigation. One of the components of this that's a debatable piece of it is whether or not routine electrocardiography should be a part of this. We don't believe it should be because of the rarity of the disease and the frequency with which there are nonspecific findings on the electrocardiogram that could lead to lots of expensive workup with no fruit at the end of that path. So I think the two things are making sure that people know their own personal family history, prospectively acting on those histories, and being able to react quickly should an adverse event occur.
All right, thank you so much. Thank you, Mr. Chairman. I yield back.
Gentleman yields back, and now recognize Mr. Griff with 5 minutes.
Thank you, Mr. Chairman. Appreciate that.
Ms. Eshu talked about the need to provide comprehensive mental health coverage for healthcare workers. It's interesting that this week in the Richmond Times-Dispatch, that would be February 12th, and I'm just going to read you the first two paragraphs. Dr. Trudy Shahady was feeling burned out. It was during the height of the pandemic, and 3 unvaccinated patients had died of COVID-19 in the span of 1 week. She needed help, she decided, so she called a program that existed nowhere else in the country, one that allows doctors to seek therapy without putting their careers in jeopardy. This was a Virginia program Virginia has been leading, and one of the programs they implemented was a secure subscription portal that healthcare workers can buy into. This program allows health workers to seek discreet therapy without a fear that they will lose their jobs, or the mere fact that they called in and asked for help and got help would be used against them in every single malpractice case brought up after that point. But with protocols in place, the program had protocols in place for reporting certain instances. Over 8,000 workers in Virginia have taken advantage of this program. Mr. Feist, what more can be done on top of reauthorizing these important programs at the federal level, but won't hamper what the states are trying to do? Because obviously, states are innovative sometimes.
States are innovative, and let me go beyond what Virginia's doing just to highlight it for the committee, because Virginia really is leading the country. No pressure on your other states, by the way. Their goal in Virginia is to be the best place to take care of healthcare, to take care of patients. And so the program you're speaking of is the Medical Society of Virginia's Champion Safe Haven program. Last year, the Virginia governor signed a new law into place which puts every single licensed health worker in 62 different health professions. That's 500,000 licensed health workers in Virginia now no longer have questions on their licensing applications that talk about their prior mental health treatment or diagnosis. This change that Virginia made, as I said, is benefiting 500,000 health workers, and that is the kind of leadership that we need to see across the country when it comes to one of the 2 top barriers to accessing mental health care that healthcare workers have. The first is your license. The second is when you go to work for a hospital and your credentials. Ms. Eshu pointed out that there's over 6,000 hospitals in this country. Well, in the last year, in addition to changing the law in Virginia, 75% of the hospitals removed their questions from their credentialing application. That's when you go to work at a hospital. You need to be able to answer these questions, and they're often overly invasive and drive this stigma. So what we're trying to do is get at the primary cause of suicide of health workers, and that's what others can do, is to really very, very artfully just take a look at those questions that you are asking of your health workers and recognize that in those questions, you are creating structural stigma that drives suicide, prevents mental health treatment, and is one very important way that your healthcare workers can feel valued and supported.
And the article also touches on the high rates of suicide amongst our healthcare workers. Mr. Chairman, I know the other side hadn't seen it, so I'm happy for it to be reviewed, but I would like to have that article from the Richmond Times-Dispatch entered into the record if there's no objection, but I'll give them a chance to take a look at it first. We'll pass that on down. Without objection. I'll now move to Mr. Strozek. Thank you so much, Mr. Feist. Calls to the poison centers across the country increased by 82% from 2021 to 2022. In 2022 alone in Virginia, there were more than 1,200 calls into poison centers for THC-related incidences. I have legislation that would attempt to create a regulatory framework for these products because the FDA has dragged their feet in addressing these products, leaving it to be kind of like the Wild West out there, and it affects children, it affects others, but it particularly is affecting young people who buy this stuff at the convenience store and think it's like candy because it comes in gummies. Have you had experience with your ambulances being called to address CBD issues?
We have had issues and calls related to that. Specifically, you raise a very good point about the issuance of candy, alternative administration of THC. This has grown. Mom and dad have it at home. The young child gets it. It's unknown. It's not regulated necessarily in terms of dosages. Equally true is these modified medications or modified therapeutics that you find at 7-Eleven or whatever, and in some cases these have adverse effects. In the state of Washington, I believe 2 years ago, a gentleman overconsumed, and I can't name the product, he went out They were later on shot 2 people. It was an incredibly tragic event. And yet these things are not protected. They're on the counter. They're not age regulated. And we have seen an increase of effects by these.
Yeah, I appreciate it. My time is up. I've got lots of other questions I'll submit for the record, but I yield back.
Gentleman yields back and now recognize Mr. Cardenas for 5 minutes.
I'd like to thank Chair Guthrie and Ranking Member Eshoo for holding this hearing today, and I'd like to thank all of our witnesses for lending your expertise and your opinions for this hearing today. I'm glad to see so many critical programs discussed today. I want to start by talking about uncompensated caregivers who play a key role for our broader healthcare ecosystem. In fact, 83% of help to all older adults in the U.S. is from family, friends, or other unpaid caregivers. This is an issue that touches so many families, whether it is those who are blindsided by a devastating diagnosis or those who are providing care to a loved one with disabilities or debilitating illnesses. Providing a high level of care is a 24/7 job, and for far too many, help is not on the way. That's why I'm grateful to be co-leading the Lifespan Respite Care Reauthorization Act with my colleague, Rep. Molinaro. This bill reauthorizes a program that offers a life raft for so many who need a reprieve. My first question is for Dr. Pike with the Alzheimer's Association. Can you talk a bit about what respite care is and why it's so critical for caregivers and their patients?
Thank you, Representative Cardenas. Every day, millions of American families are faced with unexpected illness, disease, or disability. And with each situation, a caregiver could be behind that individual. And one thing we hear often is those are family caregivers that play a unique role. As I highlighted in my testimony, in the case of Alzheimer's and dementia, there are 6 million individuals living with Alzheimer's and 11 million of those caregivers for this disease. Compared with caregivers with other diseases, caregivers for those with Alzheimer's and other dementia face unique challenges, stressors, and needs. The Lifespan Respite Care Program recognizes that vital role of caregivers and has a proven track record of supporting their overall health and well-being by providing them with much-needed respite for their care responsibilities. Thank you.
Thank you. In your testimony, you note that for patients with Alzheimer's or dementia especially, caregivers provided an estimated 18 billion hours of unpaid care just in 2022 alone. And what does this program mean for those individuals who are working around the clock to provide necessary care? And how are these resources particularly helpful for caregivers in medically underserved communities?
As I mentioned, those individuals caring for someone with Alzheimer's or another dementia, they have impacts that are related to emotional, financial, physical difficulties that outweigh caregivers of other diseases or have a increased burden on them. This type of program gives them time. It gives them time to, in essence, recharge their battery and be able to provide care in a way that is of higher quality within the home. For those that are underserved or in a underserved community overall, this program is important from the standpoint of being able to provide essential resources that they may not have access to.
Thank you. Mr. Chairman, I want to make sure that to mention the importance of legislation that extends the Stop, Observe, Ask, and Respond to Health and Wellness Training Program, which will improve health practitioners' ability to identify and support victims of trafficking. Since I'm almost going to be out of time, I want to make sure that I submit for the record this testimony called Heal Trafficking Doc.
Without objection.
Okay. Thank you, Mr. Chairman. With my time remaining, I'd like to ask Dr. Tomaselli with the American Heart Association. Dr. Tomaselli, in your testimony, you note that fewer than 10% of adults with CHD are receiving recommended care. That's congenital heart disease. Why is access to appropriate services so inadequate, and how will the Congenital Heart Futures Reauthorization Act improve care protocols?
Representative Cardenas, thank you for your question. I think there are a couple of answers to that. One is failure to recognize that, in fact, patient does have congenital heart disease in the first place. That's probably a minor piece of all of this, but there may be, and I think this came up in another question by another one of the representatives, there may not be an adequate workforce to actually provide the care for many of these patients, particularly in parts of the country where specialized care is not available. I think this really speaks to another mandate, and that's the mandate of making sure that we have a team approach to the care of these patients. Not every care provision needs to be by a doctor, but there are highly trained and nurse practitioners, registered nurses, PAs, and others who are part of a care team who can provide care under the direction of a physician for these very specialized disorders. And we can also take advantage of what's happened over the last couple of years with COVID-19 in telemedicine and leverage telemedicine actually for provision of care in places where it might not be readily available.
Thank you. My time having expired, I yield back, Mr. Chairman.
Gentleman yields back. I now recognize Mr. Latta for 5 minutes.
Well, thank you, Mr. Chairman, and thank you very much to our witnesses for being with us today. In the United States, we have the privilege to access many cutting-edge medical devices and pharmaceuticals. What was once almost impossible to treat, such as Alzheimer's or rare cancers, now have hope due to American private industry innovation. Dr. Anna Ziuata, I hope I pronounced that correctly. Advancements in our biopharmaceutical and medical device industry have allowed us to detect cancer earlier and save lives. Could you expand on how screening and early detection more broadly are critical to reducing the burden of cancer on patients and the healthcare system ultimately out there to save lives?
Sure, absolutely. So screening and early detection, I'll just put it this way, it's much better to not get cancer than to get cancer. So the screening and early detection allows people to identify cancers at a precancerous stage or before, or at a very early stage of cancer. When a cancer is diagnosed at an early stage, it's much easier to treat. It's much less burden on the healthcare system. So if cancers can be detected early, this would make a huge impact. Cancers that are detected later require much more chemotherapy, radiation, hospitalization, and put a huge burden on the healthcare system. Also, people who are uninsured or underinsured will not have access to those cares or have difficult access to those treatments. So the effect of cancer screening and early detection has a huge impact on the American population.
Let me follow up, because each year, we're getting closer to hopefully defeating cancer, and particularly breast cancer. And women between the ages of 50 to 74 access screening every 2 years. This reduces death by about 26%. We all want to get that number to 100%, up from 26, but what tools are out there that can help achieve this goal today?
So the tools that are out there, I think the Screens for Cancer Act is something that can really make an impact on the approaching cancer and preventing cancer in women who are uninsured or underinsured. I think the amount of resources invested there should be maintained and can really help decrease the incidence of cancer and the detection at an early stage.
Well, thank you. Dr. Pike, over 220,000 Ohioans suffer from Alzheimer's. In addition, it's estimated that 6.7 million Americans 65 and older lived with Alzheimer's in 2023. And about 1 in 3 seniors will die with Alzheimer's or another dementia. I'm pleased to see that the reauthorization of the BOLD Act was included in today's hearing. What else can Congress do to eliminate this disease?
Thank you. Congress continues to play a critical role in the fight against Alzheimer's and other dementia. And we're so pleased and grateful that Congress continues to invest within the scientific progress that we are seeing and the funding that NIH receives. Over the past decade alone, we've seen significant increases within that research funding. And while we have a tendency to focus a great deal on scientific progress, we also have to think about the reasons why we do that. It's the families, it is the people, and the ways that we can continue to contribute to support the caregivers that are also supporting those living with Alzheimer's. We have to consider the barriers these families face in their daily lives, like the caregiving support that they need, increased access to early and accurate diagnosis to support individuals who may have concerns about their cognition, and certainly a more coordinated, high-quality care that we can provide within the healthcare system.
Well, thank you.
Thank you.
Dr. Strozik, or Mr. Strozik, excuse me, despite, despite not being federally legalized or approved by the FDA, hemp-based THC is being added to a wide range of food and beverages, often with packaging marketed to children. Numerous reports have highlighted that calls to poison control centers regarding cannabis have dramatically increased around the country. In Ohio, for example, one such report indicated that calls focusing on marijuana edibles were up 115% from 2020, and experts expect that number to continue to rise in Ohio since the Ohio's new recreational marijuana law has been implemented. Given that many of these poison control calls involve children, what should states and the federal government be doing to ensure these products don't end up in the hands of kids?
Thank you, Congressman. As a parent and a grandparent, I think it's imperative that rules be established and clearly be identified. This is not a toy. This is not something that should not be treated as any other medication, and/or, of that matter, the assumption of consumption of alcohol. So I think it requires both public education, public knowledge, and public awareness of the effect that these medications, these over-the-counter drugs, these legalized drugs, will have on children. It's not a short high. This is significant overdosing for children. And I think public awareness needs to be significant on this, as well as discussions of protection, containerization, and clearly making everyone aware that access to this has a downside. That being said, equally to your poison control comment, we've seen an increase of children being exposed to opioids because it's commonly about, and we need to educate everyone that our environment has become more at risk today.
Well, thank you. I'm sure my time has expired and I yield back.
Gentleman yields back. I recognize Ms. Dingell, 5 minutes.
Thank you, Mr. Chair. I want to begin by discussing the Charlotte Woodward Organ Transplant Discrimination Prevention Act, which is legislation I'm leading alongside my friend Rep. Kamek. Thank you, Rep. Kamek, for your partnership on this important issue. This bill will prohibit discrimination against people with disabilities in the organ transplant system by ensuring eligible individuals are not declined a life-saving transplant based on their disability. The bill is named for Charlotte Woodward, who is an incredible young woman who was born with Down syndrome. It's fitting today is Valentine's Day and National Donor Day, since Charlotte received a life-saving heart transplant in 2012. She celebrated her 12th heart anniversary last month and has dedicated her life to advocating for people with disabilities to receive equal access. Charlotte's actually in the audience today. Charlotte, would you just stand up and wave so everybody can see you? Thank you. So she inspires all of us, and I want to wish her a happy Valentine's Day and everybody else, and I hope my colleagues will join me in supporting this legislation. Ms. Siwu-Winton, can you briefly explain why this bill is so important to the disability community, and where is discrimination most often appearing in the transplant system decision-making process?
Absolutely. I'm a mom of a 20-year-old with Down syndrome, and the idea that if she were in need of an organ transplant and that she would be denied solely because somebody read Down syndrome would be infuriating and also is inhumane and unethical. So this legislation is really important, even though there are 40 states that have laws that are supposedly preventing discrimination. There are still 10 states that don't have it. In addition, the states that do have it, it's not consistent in the way it is administered. It's not consistent in the way that there is penalty if you break it. And then how do you actually pursue, with the Office of Civil Rights, we have this pathway to pursuing, if you want to sue because you haven't gotten it, because people have been unethical. So I think for all those reasons, it's hugely important that we pass this bill. And I'm just so proud that we have a person like Charlotte in our community who has had that experience. And I think naming it after her is beautiful. So I do think this is going to make a huge difference.
Thank you.
All across the board. Thank you.
Now I got a lot of bills here, so I'm never going to get to all my questions, but thank you. Now I want to turn to Dr. Lorna Breen, Healthcare Provider Protection Reauthorization Act, which is legislation I'm leading alongside Representatives Wild, Carter, and Kiggins. This bill will reauthorize Dr. Lorna Breen Healthcare Provider Protection Act, which was originally passed in 2022. I want to thank Mr. Corey Feist for being here to share Laura's story and reiterate why it's critical we continue building on our efforts to support the men and women who, as you write in your testimony, work tirelessly to save other people's lives, often at their own personal risk. Mr. Feist, can you elaborate? I'm going to ask you to do this quickly because I got one more bill to get to, too. Can you elaborate on the lessons we've learned over the past 3 years since the enactment of the Lorna Breen Act?
Sure, and thank you so much for being a co-sponsor. To be brief, because I could take 4 or 5 hours in answering that question, what I would say is one of the things that we've learned is that the root cause of the burnout of our physicians, nurses, and other health workers can be tied to a number of things, but the primary reason is the increased administrative burden that they carry. When you think about the fact that over 50% of a nurse's time and over 70% of a physician's time is spent away from the bedside doing administrative work, not only would I argue that we don't have a healthcare workforce crisis, we have a workforce doing the wrong thing. They're the only ones trained to take care of us, and they're doing administrative work. So that's driving burnout. The other thing that I would just say is that healthcare leaders need to be given the tools now to help focus on the impact of the work on the workforce, not only looking at patient care. Thank you.
I have more questions for the record for you, and I have a letter for the record I'd like to insert as well from FIGS, Mr. Chairman.
Without objection.
Thank you. As co-chair in my last seconds of the Emergency Medical Service, or EMS caucus, I care deeply about the EMS workers. They're often the first to arrive at the scene of emergency. They have to quickly evaluate and determine the best course of action. That's why I've introduced the Siren Reauthorization Act alongside Rep. Joyce. Housed within the Substance Abuse and Mental Health Services Administration, Siren grants grant support and public nonprofit rural EMS agencies in their efforts to train and recruit staff. I'm going to ask Mr. Strug one question and do more for the record. Do rural communities have the resources to sufficiently recruit and retrain EMS personnel?
They are doing their best, but no, there's a shortage across the country, both in terms of staffing, resources, new latest equipment, and ability to deal with the closure of hospitals across America.
Thank you. Mr. Chairman, I got several other bills I wanted to speak on. I got more questions I'm going to submit for the record, but I look forward to working alongside my colleagues to reauthorize many of these important public health programs without delay. Thank you, and I yield back.
Gentlelady yields back. Recognize Mr. Bilirakis, 5 minutes.
Thank you, Mr. Chairman. I appreciate it, and this is really a great hearing. Thanks for holding it. So again, H.R. 7189, the Congenital Heart Futures Reauthorization Act of 2024. I'm one of the co-sponsors, the lead co-sponsor, and I want to thank my colleagues again for co-leading, Soto, Carter, Schiff, Salazar, and Cardenas. This critical legislation will ensure the continued investments needed at HHS to understand and assess the lifelong needs of congenital heart disease, or CHD. Since this program was originally created, we've seen the needs of patients living with CHD evolving over the years. In the past, you've heard me talk about Nicholas Baskin, who was born with congenital heart disease and required heart surgery at just 2 days old. While I'm glad to report that Nicholas graduated from high school last spring and is pursuing music writing, his decision to stay in the Chicago area for college was certainly affected by his access to adult congenital heart care. Other more rural areas, unfortunately, do not enjoy the same access to adult CHD care. And this transition from pediatric to adult care for CHD patients is a critical period that requires specialized coordination of care, especially that there are now more adults than children living with congenital heart disease because of your great work. And this isn't just in the rural areas where we have a lack of adult congenital heart physicians, even in my area, the Tampa Bay area, which is not considered rural. Dr. Tomaselli, I want to thank the American Heart Association again for their support of H.R. 7189. Do you have any suggestions for how we can expand and strengthen the congenital heart program to focus on the unique lifelong needs for adult congenital heart patients through workforce development training measures, particularly when we know there's a shortage of cardiology care nationwide? Now, I know you addressed this, but I want to give you an opportunity to expand upon that, sir.
Representative Bilirakis, thank you very much for the support of this bill. Well, the American Heart Association appreciates your work on this. And as you recognize, the workforce shortage is not unique to this particular problem in cardiology, more in medicine more generally. And I think one of the goals of some of these bills is to provide education about some of these conditions. And we find that actually getting into schools and engaging people early on what needs to be done, for example, in a cardiac emergency, or what are the components of these bills, allows us to draw in younger people who might be interested but don't know it yet, that they might be interested in a career in medicine or biomedical research. So this legislation not only provides care, education, and training to those providing care, but an opportunity and a stepping stone for others who might want to be engaged to get engaged. I also think it's really important to recognize that regardless of the medical problem, team care is essential, and making sure that we not only recruit physicians, but we recruit other allied healthcare providers who provide an important component of care, particularly at the transitions, and oftentimes are the ones who are following patients through that transition from childhood to adulthood. And one other thing that I think is essential is that really taking advantage of the fact that we can now meaningfully do some things in telemedicine and actually allow primary care providers or non-specialized providers who are out in the community to communicate with the specialists who might not be available immediately, but would be available to provide consultation and help with management of patients. So I think this fully expands the whole, not only degree-bearing providers for healthcare, but also expands the regions in which this care can be provided. So I think all of these things, and they're all components of the two bills under consideration, and by the way, the AED access bill as well.
Thank you very much. Dr. Pike, I'm thankful you're here. I've been such a strong advocate for Alzheimer's patients. Something that's clear and really dear to my heart. My mom is suffering from Alzheimer's disease now, and the caretakers, as has been said, it's a really, what a burden on the caretakers. I was proud to recently co-sponsor Representative Tonko's NAPA Reauthorization Act, which extends the National Alzheimer's Project Act. And in fact, we modeled Representative Tonko and I modeled our legislation, the National Parkinson's Plan, after the Alzheimer's Plan due to its accomplishments. Can you provide specific examples of these successes, how the National Alzheimer's Project has helped advance Alzheimer's research and care, and why this model has worked at the federal level, sir? I know you don't have a lot of time, but this is really important.
It is important, and thank you for asking the question. I will try to keep it brief. The NAPA reauthorization is incredibly timely right now as we look at the progress that we are making in this disease. We have treatments for the first time. We have diagnostics that are going through the pipeline. And part of that is because of the 7-fold increase that we have seen in research funding coming out of NIH over the last 10 years. Being able to coordinate across federal committees, federal departments, and agencies is incredibly important to continuing that progress with the NAPA reauthorization, and take what we have learned from the last decade of science, including on risk reduction, and fold those new pieces of information and new agencies into the act.
Thank you very much. I guess I ran out of time and went over them. I apologize, Mr. Chairman. I yield back the balance.
I'll take it
Whatever.
off your time for the next hearing. No, I'm just kidding. That's a joke. I won't do that. Gentleman yields back. I recognize Dr. Ruiz. 5 minutes.
Thank you, Mr. Chairman. As an emergency medicine physician serving in a rural and underserved area, I can attest to the urgent need for programs that support emergency medical services. And as an alumni of the great University of Pittsburgh affiliated residency in emergency medicine, where we basically do the pre-hospital care research, I have a deep appreciation of pre-hospital care. In the emergency room, I have seen how the emergency care that patients receive on the way to the hospital can make a significant difference in patient outcomes, and in some cases could be the difference between life and death or even life with permanent disabilities. Providing emergency services for patients in rural areas is challenging due to factors like physical distance, workforce shortages, and reimbursements that do not cover the costs of care. More work needs to be done to improve patient access so we can ensure people are getting the emergency care they need when they need it. And part of that objective includes addressing workforce shortages and building up a robust and skilled healthcare workforce. That is why programs that help recruit and retain paramedics and emergency medical technicians, EMTs, as well as ensure emergency responders are equipped and trained to treat all individuals are vital. And it's crucial that, when necessary, we reauthorize these very programs. Look, I spent this the Super Bowl Sunday watching the Super Bowl at the CAL FIRE, Riverside County Fire Indio Station 80 with the folks from Station 80 and Station 87 to show them my appreciation. And we're made from the same cloth. They're incredible individuals who put their life on the line to help others and to save lives. And while I was there, they were called out to the field. And so Station 87 took it because the captain of Station 80 was a big 49er fan and he gave them a break. So you know how it goes. One of those programs up for reauthorization in HR 6960 is the Emergency Medical Services for Children's program. This program helps ensure children receive appropriate health care during a medical emergency. Another program being considered for reauthorization today is in HR 4646, the Rural Emergency Medical Services Training Program. This program focuses on recruiting and training EMS personnel with a focus on addressing mental health and substance abuse disorders. According to the National Rural Health Association, 4 out of 5 counties, 4 out of 5, have at least one ambulance desert. In fact, in certain parts of my congressional district, the average EMS response time is 1 hour. 1 hour, Dr. Bouchon. A person with a stroke, heart attack, 1 hour or more. This puts patients' lives at risk. We must do better to ensure patient access. So, Mr. Strozek, EMS plays an incredibly important part in helping patients access to care and connecting patients to different care locations like local hospitals and tertiary care. How can EMS be better utilized to reduce delays in care?
Well, thank you, Doctor. I think your response in your testimony or reading of this is totally correct. I think here's an imperative point. Let's just use one extreme example, and it relates to the cardiac issues we've been talking about. Early detection of an infarction, transmission of that information to a tertiary facility, and the rapid transfer of that patient from home either to an initial hospital or later to the tertiary hospital where they can receive cardiac catheterization, open heart procedures, whatever, has a net savings to America, not only in terms of that person's life, but in terms of the downstream care. 30 years ago, it would not be thought of that a paramedic from the scene would be recognizing an infarction and getting the patient quickly from the point in time of onset of pain to needle time. Yeah. Today, we have that in record levels.
Yeah.
Equally, in turn, is if we can find means through programs there whereby the EMS provider goes to the scene, does an evaluation of a patient, but doesn't necessarily have to transport that patient to the most expensive level of care, an emergency room, and can refer that patient either to a freestanding clinic, take that person to a freestanding clinic, and/or provide them additional access and resources to mental health.
In my 10 seconds left, I've been talking to a lot of the paramedics and EMT and fire folks back in my district, and, they are incentivized to take the patient to the hospital, even when they don't have to, because the only time they can get paid is by delivering patients to a hospital. Now, you know that there's patients who get called for mental status changes. And the paramedics go there, they realize they're diabetic, they didn't eat, they're hypoglycemic, they give them their D50 or they give them some snacks, they get better, they're fully awake, alert, they're like, it's done, they can stay home. They provide life-saving care at the home and they don't get reimbursed for that. That has to change, and we have to change it in this committee. They deserve better. Thank you.
Thank you. Agreed. Gentleman yields back. I now recognize myself for 5 minutes. I was a cardiovascular and thoracic surgeon prior to being in Congress. I personally operated on 2 patients in my career who survived out-of-hospital cardiac arrest due to AEDs. And in my practice, we did all the screening echoes for the college athletes at University of Evansville looking for undiagnosed cardiomyopathy. Dr. Tomaselli, I appreciate your testimony and expertise in cardiovascular-related issues and support for the HEARTS Act and the Congenital Heart Futures Reauthorization Act. Your testimony, you also discussed the Bipartisan Access to AEDs Act, which seeks to increase access to AEDs at K-12 schools and provide cardiac arrest plan training. Would you quickly remind us how an AED is used during a sudden cardiac arrest?
Thank you, Chairman Dr. Bouchon. We speak at the American Heart Association of a chain of survival, and that chain of survival includes 5 links. The first 2 links are activating EMS, providing CPR, and the third link is the AED, which is nothing more than a computer that's hooked to a battery that has a couple of patches that can do 2 things: record the cardiac rhythm and deliver a shock. So these devices do an exceptional job at rhythm interpretation, and they are now designed in such a way that there are voice prompts and they're very easy to use. Training makes it even easier because people feel comfortable with these devices. What they do is they detect an irregular and fast heart rhythm and will deliver a shock to correct it. Some of these devices also can detect a very slow heart rhythm and deliver a lower energy shock to pace the heart, to increase the heart rate. So again, it's important that this be included in a total program of a cardiac emergency response plan, but this is a critical piece of it.
Agreed. I want to lean on in on the training aspect of the bill and make it clear, in my view, that lay people with no medical training can use these devices if they can get over their initial fear of using them. I mean, in medical school, they always said when you respond to a code in the hospital, first thing you do is take your own pulse. And they say that because, trained people can control their emotion, help control their emotions, and can respond properly, and that includes lay people. I recently was at an airport, believe it or not. There was an unwitnessed arrest in a bathroom, and when I arrived, my daughter kind of came out of the women's bathroom and said, something's going on in the men's bathroom. I went in there, and there was an airport security officer there standing there not providing CPR, and had not asked for an AED, and I provided CPR and then asked them for an AED. I think it was out of fear and not proper training. So many public spaces already have these, and some states even require schools to have AEDs, although the laws aren't necessarily funded. In addition to access to the device itself, why is it important to have a sudden cardiac arrest plan immediately set in motion to save lives?
I think this is a fundamentally, essentially important point here. If you have an AED, but nobody knows where it is, and nobody's willing to use it, it becomes an expensive piece of wall art that doesn't help anybody. So having a cardiac emergency response plan does a couple of things. It actually provides the therapeutic treatment strategy for people and provides training so that they feel comfortable doing things and not causing harm. It also allows for the entire team, and there's a team of individuals who are responsible for this, to drill and to train, like you would have a fire drill, so that when the event happens, you know what to do and you know how to do it. So I think these are important. And I think the 2 bills, the HEARTS bill and the congenital heart disease bill, as well as the AED bill, all provide educational training for a number of these things, and I think are synergistic. In terms of what the federal government can do, I know that a number of states are working on passing legislation for CERP plans in schools. Some have mandates, but some are contingent upon other forms of funding, either from the federal government, from grants, from donations. I think having the federal government step up in the Access to AEDs Act and these other two bills could, I think, help the states move move these initiatives forward. So thank you for your support.
Thank you very much. I would totally agree with that. Dr. Annunziata, thank you for being here and for your partnership in fighting against cancer. Although not part of today's hearing, I'm also want to highlight legislation that I have with Congresswoman Yvette Clarke, the PSA Screening for Him Act, previously with Bobby Rush, one of our former committee members, legislation to eliminate the copay for at-risk men to receive prostate cancer screening, and this has been in the news recently with one of our cabinet secretaries, as everyone knows. We know that screening cancer can save lives. Do you think not having a copay and taking down financial barriers to screening, for example, for prostate cancer with a PSA for Him Act could make a difference?
Yes, absolutely. I mean, I think that the American Cancer Society Cancer Action Network supports the PSA for Him Act. There's many potential benefits of this. As we know, prostate cancer survival rates increase when the disease, survival rates increase when the disease is detected early. So it's really essential to remove all barriers to getting this prostate cancer screening test. The screening can help detect prostate cancer at an early stage, often before signs are even present, before the disease becomes more advanced. And as I talked about in my previous comments, this is really essential to improving the survival of.
Thank you. My time has expired, but I couldn't agree more. Thank you very much for those comments. I now recognize Ms. Custer for 5 minutes.
Great, thank you, Chairman Guthrie. I appreciate it. Thank you to our panel. I'm pleased to see this committee is dedicating time to reauthorizing these critical health programs, and the list is impressive, supporting premature infants to funding stillbirth research and prevention and committing federal resources to fight Alzheimer's disease. This committee, once again, is working to improve the healthcare system for Americans all across our country. In my experience caring for my mother, she lived with Alzheimer's disease. I've seen firsthand how hard the challenges of aging and caring for older adults can be on families and caregivers. I'm proud to co-sponsor 2 bills that would build on the progress that we've made in Alzheimer's research and treatment over the last decade, the Alzheimer's Accountability and Investment Act and the NAPA Reauthorization Act. As we invest in new treatments and therapies, it's more important than ever that we continue funding to detect the disease early and that we do everything we can to improve healthcare outcomes. So Dr. Pike, could you share some of the breakthrough research and technologies that federal investment has made possible over the years?
Thank you for the question. I think this is an incredibly important one. As I've mentioned before, the Alzheimer's Accountability and Investment Act really takes what we are hearing from scientists at NIH and applying what they believe they need in order to make advances against the NAPA Act, asking them how much investment they need for the professional judgment budget in order to make progress against what we are seeing. As a result of this, we've seen a 7-fold increase in research funding over the last decade. And we anticipate that that need is going to grow as we continue to see advances and the knowledge that we are learning out of this research. One of the biggest things I would comment on from the standpoint of what we are seeing and what has been invested so far is on diagnostics and the importance of diagnostics within the process of identifying early, and being able to move people into either care pathways, quality care, or now that we have treatments that treat the underlying biology of the disease, the importance of being able to identify those individuals early. NIH funding, NIA funding has led to some of those breakthroughs with blood diagnostics in particular, efficient and effective ways to diagnose Alzheimer's into the future. But the other side of that is it also identifies individuals who may not be eligible for treatment. It gives us more information about those dementias and gives us the ability to provide better research on ways to create pathways for treatments for those other dementias, while also getting individuals into treatment and improving the treatments for those with Alzheimer's.
Very helpful. In your testimony, you mentioned the need to an updated national strategy to fight Alzheimer's disease. Could you briefly discuss some of the changes to the advisory council that the NAPA Reauthorization Act would make?
I would highlight two specific areas. And one, the first one I would highlight is because of the increased knowledge that we are seeing around risk reduction. The ability to add a sixth goal to the National Alzheimer's Project Act on looking at risk reduction and ways to reduce risk for Alzheimer's and other dementia. That is number one. Number two is that it takes the knowledge that we have seen over the last decade and includes more agencies from the federal government, for instance, like Social Security Administration, FEMA, within the within the NAPA Advisory Committee in order to help coordinate the outreach and the work that we do.
Great, thank you. Investing in advanced diagnostics and innovative treatments is deeply personal to me and many of the families of my constituents across my district. I urge my colleagues to support reauthorizing these important programs to fund continued research and improve early screening, prevention, and treatment now that it's available while we work to find a cure for Alzheimer's. With the remainder of my time, very briefly, I'll turn to rural health. Question for Mr. Strozik: how are Siren grants helping rural communities in New Hampshire and across the country?
Well, New Hampshire is an ideal state to look at between your urban and your rural areas. It's, real quickly, it's training, it's education, it's recruiting new community members to be part of their EMS system. It's the purchase of AEDs and advanced cardiac monitoring equipment. It's advanced levels of care, be it advanced airway management for cardiac patients, but it's also working to develop new programs, as to Dr. Ruiz's point, where we can now not take the patient to the most expensive means, but we can find means of taking them home and taking care of them. So New Hampshire has been very strong for that, and I'll just one quick shout out to your folks. New Hampshire has one of the finest programs for recognition and treatment of opioid overdoses by law enforcement, EMS, and community healthcare workers. So thank you.
Thank you. Thank you very much, and I'll yield back.
Thank you. The gentlelady yields back, and the chair will recognize Dr. Dunn for 5 minutes for questions.
Thank you very much, Mr. Chairman. We have a lot of common sense proposals before us today that represent our federal investment and commitment into the well-being of our nation. It's important when we reauthorize these programs that we evaluate the changing healthcare needs of our population. The SARS-CoV-2 pandemic certainly identified some weak spots in our public health infrastructure, as well as left us with new challenges, for instance, related to mental health. Many public health needs persisted, such as the need for early and accurate cancer screening, an initiative that's near and dear to my heart from my many years of medical practice. What has changed remarkably is the technology that's now available to providers to detect cancer earlier. And in spite of this, I have to say we're still seeing the Preventive Services Task Force dragging their feet to recognize the improvements in early diagnosis, and thus they end up obstructing access to early diagnosis. Dr. Annunziata, thank you for appearing with us today on behalf of the American Cancer Society and also on behalf of patients and doctors everywhere. Would you agree that there are, in fact, vast benefits to patients and to the healthcare system in terms of quality of life and total cost of the system when cancer is detected in its early stages?
Absolutely. It's better to detect, as I mentioned earlier, it's better to detect cancer early, even when it's a precancerous lesion, and this vastly improves lives, yes.
So I think in this, so that's both the patients obviously benefit, but the costs to the system go down. And I think there's another benefit that we talk about less frequently, which is the benefit to all of society in preserving human capital. In my opinion, we still fail to put enough emphasis on early and accurate diagnosis of many potentially lethal diseases. I know the American Cancer Society is prioritizing passage of H.R. 2407, a bill I co-sponsor, led by Representatives Hudson, Ruiz, Arrington, and Sewell. And this bill will ensure that Medicare beneficiaries can benefit from multi-cancer early detection blood test screenings. Can you briefly tell the committee why this bill is so important?
Yes, so the Multi-Cancer Early Detection Act, it will support Medicare paying for any multi-cancer detection test. Multi-cancer detection tests are moving forward and are currently available in the network, but there are barriers to paying for that. So we support, the American Cancer Society Cancer Action Network supports removing that barrier to payment for this test.
I do too. Thank you very much. Mr. Corey Feist, I appreciate your insights. I commend your advocacy related to physician burnout. It's another issue that's personal to me and that each of us here, I think, care deeply about. Our physicians, doctors, and their staffs are, clearly they're dedicated to their patients. They remain steadfast to the oaths that they have taken, but this faithful commitment to their patients can take a hard toll. The quotes you shared in your testimony are a testimony to that fact. The SARS-CoV-2 pandemic exacerbated the plight of the burnt-out healthcare workers, which is too often revealed in heartbreaking stories like that of your dear sister-in-law, Lorna Breen. You mentioned that 44 organizations have been able to take advantage of the Lorna Breen Act funds since its implementation, although there's more work to be done. I'm supportive of the reauthorization of this program, H.R. 7153, which would do so. Would you please briefly share some of the creative programs that you've seen that stand out utilizing the Lorna Breen grant money?
Thank you so much for your support of our bill and healthcare workers such as yourself. It has been amazing to see the work in a relatively short period of time. If you think about the healthcare industry didn't just get here overnight. As you say, the healthcare workers, there were about 40% of healthcare workers in this country were burnt out going into the pandemic. And so it was an exacerbation. What we have seen from the grant recipients is we have seen different kind of categories of programs. So those that were providing individual support to health workers are improving mental health services. They are providing stress and trauma support, and they're incorporating wellness training into the just basic framework of the day-to-day in life. And as you know, as a physician, most of the healthcare delivery focus in this country is on the patient, and it forgoes the impact of the work on the workforce. And so these individual support programs have been critical to holding pressure on this bleeding wound of burnout, to provide these workers these essential services. On the other side of the equation, that you look at the root cause of why the burnout is caused in the first place. Many of these programs have gone to training leadership. As we've discussed already, many leaders are often focused so heavily on the patient care that they are not even sure what they have the ability to do in their own sphere of influence and control to impact the environment that drives burnout in the first place. So leadership and training has been key to these programs. Enhancing health worker solutions around reducing their workload, their administrative burden. As we know, that administrative burden continues to tick up, and every percentage that it ticks up decreases the amount of clinical care that can be provided. So that's been huge. And then there have been an ongoing efforts to really try to measure burnout and well-being. As you know, boards of directors often look very closely at these key performance
I
indicators.
think we're dangerously over time here.
I
don't want to.
Sorry about that. I didn't want to stop you, but
Thank you very much for your work.
Yeah, sure. Thank you.
I yield back.
We're recognizing Ms. Kelly. She's now recognized for 5 minutes for questions.
Thank you for holding today's important hearing. Unfortunately, stillbirths affect 1 in 170 pregnancies, with over 20,000 babies born still every year in the U.S. Nevertheless, what's more disheartening is that studies show that nearly a fourth of these stillbirths are preventable, and the majority occur in what would otherwise be considered low-risk pregnancies. Furthermore, certain groups, such as Black women, Medicaid recipients, and those living in rural areas, share a disproportionate burden of those lives lost, highlighting the urgent need for targeted interventions and equitable access to care. We've seen other industrialized nations, such as UK and Australia, invest in focused stillbirth education and prevention efforts, which significantly decreased their rates in just a few years. Dr. Pike, I know you've been talking a lot about Alzheimer's, but I'm going to go to your public health background. I'm proud to co-lead the Shine for Autism Act with my colleagues, Reps Kim, Castor, and Joyce. This bill provides funding to bolster data collection, increase perinatal pathology training, and disseminate educational materials concerning stillbirths. This legislation is crucial in addressing the gaps in research. From your public health background, do you have thoughts as to why there are gaps in public health surveillance data, such as stillbirth research, for example, and how improving the research and data collection can help us more aggressively decrease mortality in this country?
Thank you, Representative Kelly, and I am happy to offer my best response as a public health professional, but want to acknowledge that stillbirth prevention efforts are not my immediate expertise. So thank you for acknowledging that. With that said, we know that two public health building blocks are data and training. And being able to collect data, share data, improve educational materials, increase investment in research fellowships have generated positive advancements across public health, including what we have seen in Alzheimer's community. That is likely true within the work that you are doing on this act as well. Thank you.
Thank you. And Mr. Strojic, I've heard from the ground ambulance service providers in my district that they are struggling financially due in large part to Medicaid payments that are significantly less, even with the add-on payments, than their costs of providing vital medical services. Since reform of the ambulance fee schedule is likely still several years away, what happens if Congress fails to extend the add-on payments at the end of this year? And what more can we do to ensure that ground ambulance service providers remain solvent until we reform the payment system? And I even know finding ambulance drivers is tough too.
Thank you, Congresswoman. I can't imagine that if we cannot have the extenders passed, what the impact will be to a system that is already fragile and having difficulties. Medicare, for many, many years, has not met the direct cost of provision of service. This will simply just place it at a more difficult position. Every month, every week, we hear providers, public, private, who they may be, that are struggling to survive, and in some cases have had to reduce or end service. We're asking this committee and members of Congress before, as an interim sort of placement, that we need not only the extenders passed, but an additional fee or funding associated with that as an interim fix, for lack of a better term, until such time as CMS completes the cost study and comes forward with a true recognition that Medicare doesn't cover the cost of service. Systems are at risk across our country.
Thank you so much, and thank you to all the witnesses. And with that, I yield back.
Gentleman yields back. I apologize. We were discussing what was going on here. Yields back, and the chair will now recognize Mr. Carter. Mr. Carter is recognized for 5 minutes.
Thank you. I'm down here in timeout, so y'all focus down here. I appreciate it. Thank y'all for being here. This is a very important hearing. These are very important bills that we are considering. And you know, many of these bills, if not all of these bills, are bipartisan. And I think when you look at it, and I'm a healthcare professional, a pharmacist, and you know, we all want the same thing in healthcare in America. We want accessibility, affordability, and quality. All of us, whether you're Republican, Democrat, or Independent, you want accessibility, affordability, and quality. That's what we want. That's why I'm glad that we are having this hearing today, particularly as it relates to children. And I've got a bill here, a bipartisan bill, the Emergency Medical Services for Children Reauthorization Act. It's extremely important. All of us love our children. We want to make sure that we are taking care of them. That's what this bill does is it reauthorizes grants that focus on addressing the unique needs of children. And we know that they have unique needs, particularly in emergency medical systems. You know, for nearly 4 decades now, the Emergency Medical Services for Children program has been the only federal grant program that specifically focuses on addressing the needs of children in emergency medical systems. That's why it needs to be reauthorized.
Mr. Strosik, I wanted to ask you, can you explain how the needs of pediatric patients are different from adults and why it's so important for local and community hospitals to be ready to meet the needs of children?
I think, and Dr. Schreier can attest to this, children are not little adults. And the level of training, both at the EMS field for the first responders, be it paramedic or EMTs, understanding the physiology, the level of care that a child needs, as well as recognizing that children don't necessarily respond in the same way as an adult was. I'm not saying that we cry faster than a child if we skin our knee, but these things do occur. Equally true is when that child is taken to a community hospital, an initial level of care, it's that recognition and training that is incredibly important by those physicians and nurses at that facility to recognize that that child may need tertiary level care. And in our state, it's going to Children's Hospital, Mary Bridge, or wherever it may be. We have grown this level of care over the last few years, my last 40 years, from treating them as little adults to really recognizing many of these efficacies, including mental illness.
Exactly.
And
Thank you
difficult
for that.
environments.
Extremely important point, and I appreciate you bringing that up. You know, I had as a pharmacist, I dealt with nursing homes, geriatric patients, so I had the other end of the spectrum. But you're absolutely right. With medications, they're not the same for children as they are for adults or as they are for geriatrics. That's why this is so very important, particularly when we're talking about emergency situations. Because I want to get this in very quickly, I'm going to change and shift gears here and talk about another bill that we've got here, and that is I'm co-sponsoring the National Alzheimer's Project Reauthorization Act. And I believe that Dr. Pike, you discussed this in your testimony today. I'm optimistic about this and about the FDA-approved treatments to slow the progression of this awful disease. As I mentioned, I worked in the geriatric world, and I've seen this. I've seen it firsthand, experienced in my family, as I think probably all of us have. You mentioned that, Dr. Pike, you mentioned that the National Alzheimer's Project Act has led to much of this great progress that we've seen. Can you elaborate on how the national plan has laid the foundation for these and future scientific advances?
Yes, and thank you for co-sponsoring our Reauthorization Act on this. Before 2011, there was no cohesive national plan to address Alzheimer's disease in this country. Thanks to NAPA, the first ever national plan to address Alzheimer's disease was released 12 years ago, which focuses on the goals to promote rapid research on Alzheimer's disease, certainly on other dementia as well, and improve the delivery of clinical care for services for individuals who are living with dementia and also their caregivers. It provides a roadmap of strategies with HHS and its partners so that we can accelerate research. Within the last 10 years, since we have been working within the Advisory Council and the NAPA Act, we have learned quite a bit as a result of this national investment. This reauthorization gives us the opportunity to take that knowledge and build on it and make the updates to the NAPA Act along with that. So for instance, including risk reduction. The science continues to evolve on that, and we learn more.
Well, good. Thank you for that. And I might add, I've been back and forth between a Budget Committee hearing and this hearing, and the impact, the fiscal impact that Alzheimer's is going to have in the future on our budget here, that's another thing we need to take in consideration. The physical effects, the effects it has emotionally on families, on the caregivers and everyone else, yes, but the impact financially it's going to have on our budget, that's another thing we have to take in consideration. So thank you for your work in this. Thank you, Mr. Chairman, and I yield back.
Thank you for raising it. They say $1 trillion by 2050. The chair will now recognize Dr. Schreier for 5 minutes.
Thank you, Chairman Guthrie, and thank you to the witnesses today for speaking today on all of these really important public health reauthorizations. It was hard to figure out which one to talk about. I also want to thank our chairwoman, Rogers, who's announced her retirement, and she has been a delight to work with, especially being from Washington State. The Emergency Medical Services for Children Reauthorization Act is near and dear to my heart. I'm a pediatrician and have seen in clinic how quickly a child can become medically unstable. During
training, I worked in the emergency department, taking care of acutely ill or injured patients. And however scary it can be when a child is in dire straits, it is easier to manage these emergencies in controlled settings. But first responders don't have that luxury. They are the ones responding to the emergency in the field. And taking care of a child in distress is nerve-wracking, high stress, and high stakes. And EMS providers know that children are not just little adults, and they aren't all the same size. Each one needs a different type of stethoscope, an oxygen monitor, breathing tube, blood pressure monitor, and each one requires a different dose of an emergency medication in a crisis, so there's no automatic reflex with a child. I would add to that that most of the people who are providing emergency medical services take care mostly of adults, and they don't get as much practice with children, and that's where we can help. So I'm proud to co-lead this reauthorization with Representatives Carter, Castor, and Joyce. This program supports research, training, grant funding, data collection that has resulted in better emergency care and a decline in pediatric injury-related deaths by 40% since the program began in 1984. EMSC in Washington State has provided pediatric care equipment throughout the state, including pediatric pulse oximeters and breathing tubes, to EMS agencies who otherwise would not be able to keep this equipment in stock. Mr. Strozik, it is great to have you, a Washingtonian, here testifying before the committee. For EMS providers who often have to act in the moment quickly in order to save a life, can you tell us how this program has helped them handle emergencies and what gaps the program fills?
Your district may be a great example of a tale of two worlds. Half of your district is an incredibly urban place, Bellevue. You're within minutes of tertiary care. The other half of your world in Eastern Washington has vast areas where communities there, but there are not hospitals, there are not advanced levels of care. The training that exists and is ongoing today that these first responders in rural portions of Washington, across America, is the difference. They're becoming comfortable, they're becoming understanding, their ability to use advanced levels of technique, as you said, airway management, understanding that recognition of diseases has been incredibly important, as well as recognition of where the patient should go in terms of be it immediate evacuation by air or whatever to a tertiary facility.
And that's right. We use air flight in my district, and they have to, part of the reason that these kids survive, and this is why we have support from the Children's Hospital Association, which I would like to submit, is that this affects how children arrive to the emergency room, and that has so much to do with their survival. So I want to thank you for your comments and for being here. I also wanted to touch on pediatric, on provider mental health. I'm so happy that we are once again taking up the important Lorna Breen piece of legislation, because doctors are trained to put their own feelings aside and work long hours and not admit when they're having a mental health crisis. And that is the culture of medicine. So I'm glad that we are doing all that we can to help save lives. I don't have much time left, but Mr. Feist, would you like to talk just a little bit about this in the last 30 seconds remaining?
Thank you for your support. Physicians, nurses, pharmacists, every healthcare worker in this country is experiencing a mental health crisis right now. CDC just published a report in October that identified that among any type of worker class, health workers have the worst mental health right now. So reauthorizing this bill now sends a signal and support that is much needed to address the operational, cultural, and other mental health challenges that our health healers have. Buddy Carter was just in here, he's one of the co-sponsors, and he just said that it is critical, everyone wants accessibility, affordability, and quality in their care, but we can't have any of that unless we have a healthy workforce.
That's right, and it's contributing to the physician burnout we're seeing today. With that, I will conclude and yield back. Thank you.
Thank you, Dr. Shire yields back, and your action on the document we'll take at the end. If it's not on the documents list, we'll consider it with that. I think there's a documents list. So thank you. The chair will now recognize Dr. Joyce for 5 minutes for questions.
Thank you for yielding, Mr. Chairman, and thank you for our panel to being present here today. As a doctor, I too am committed to ensuring the continued effectiveness of federal resources that safeguard both public health and public safety. When I first came to Congress, I made it a priority to work on the healthcare issues that matter most to Pennsylvania, which is why I am pleased to see such an extensive list of bipartisan bills before us for consideration today. Recently, I was proud to assist in introducing H.R. 7251, which would reauthorize funding for poison control centers that play a critical role in providing expert guidance and assistance to individuals and families facing emergencies related to accidental poisonings and toxic exposures. I would also like to thank Lead Rep. Chavez de Reamer and co-leads Rep. Davis and Rep. Shafillis McCormick for their work on introducing this important legislation. I am proud to stand alongside my colleagues in support of the capacity of poison control centers to respond to emergencies promptly and effectively, ultimately saving lives. Poison control centers are staffed by highly experienced staff with a wide range of knowledge on toxins contained in everything from household cleaners to snake bites, and offer services to Americans in all of our 50 states. When seconds count, this wealth of knowledge can be called upon to deliver accurate information in an emergency. As a member of this Energy and Commerce Health Subcommittee, I'm proud to be working on this issue. It is imperative that we prioritize the reauthorization of these essential centers to ensure that they remain equipped to meet the needs of our communities. Mr. Strozik, can you briefly discuss how these organizations you represent with poison control are better equipped today than they ever were before?
Well, first, I would point out, thank you, Congressman, for your support. Poison control centers are kind of the silent provider, if you think about it. It's an incredible resource we don't think about until it's needed, be it physician level, be it EMS provider level, be it a parent. Database is a critical function of this that they've developed as they're becoming ever-increasing levels of exposure to both chemicals or, and unfortunately to this day, over-the-counter medications that should be regulated and or street drugs. These systems allow citizens, EMS providers, and physicians and caregivers to make an immediate contact to a resource that can provide information that's incredibly critical, it's timely, and provides direction for treatment and follow-up care it's needed. It's a resource and asset to our country that we many times don't think about. When you say that, and you and I are old enough to think of this, I think in the Mr. Yuck sticker that parents would put on containers and have young children recognize if the green tag is on the container, don't touch it. It's made a huge impact.
Thank you. I am also very pleased to see this committee considering the Emergency Medical Services for Children Reauthorization Act, which is a vital piece of legislation aimed at children so that they receive the appropriate care during medical emergencies. My colleague, Dr. Schreier, just mentioned that children are not little adults. I would like to thank our lead sponsor, Rep. Carter, and co-chair of the Children's Health Caucus, Rep. Castro and Dr. Schreier, for their bipartisan work on this bill. The EMSC has been a necessary tool for our pediatric health providers since it began in 1984, when I was an intern in Baltimore, and has helped in decreasing the pediatric injury-related death rate since its inception by a significant 40%. Mr. Strozik, EMSC state funding has been used for the purchase of specialized equipment and supplies to improve how children are cared for following a severe accident or during an illness. What other kind of specialized equipment and supplies are unique to children?
Well, if you think about it, everything is smaller, be it airway management, be it cardiac monitoring, the applications to use a monitor, medications. There are therapeutics by which called a Brazil tape. You may recall that from your days where we can put down and make definitive decisions on dosages for patients. There are warming equipment that is needed for very, very young children, for neonates that need to be protected. And then across this country, we've developed some very high-level technology of moving newborn patients and young patients from primary care facilities to tertiary facilities that have changed their life and allowed high levels of recovery. Today, we have units running around the country that have levels of technology that are miniature neonate units on the road. So all these things exist, and first and foremost, we are training our EMS providers to, as I said several times today, and I'll repeat it again, children are not little people, not little adults, that they are grown, that they have a special need. And as a paramedic from the old days, a child was scary. Today, it's a critical part of the education program.
Mr. Strozik, do you feel that innovation, particularly medical device innovation that you just talked about, allows for American children, American lives at risk to be saved?
Absolutely, without a doubt. We have made an impact.
Thanks.
Thank you. My time has expired, and I yield.
Thanks, Dr. Joyce. Yields back. The chair recognizes Mr. Sarbanes for 5 minutes for questions.
Thank you very much, Mr. Chairman. Thank you all for being here today. Very powerful testimony on these important bills that we want to reauthorize that can strengthen critical primary, preventive, and emergency health care programs. When I talk to the healthcare providers in my district, and by the way, before I came to Congress, I spent almost 20 years representing various healthcare providers, so there's been an ongoing communication channel there for some time. Two of the most pressing issues that come up over and over again are healthcare workforce challenges, we talked about it today, and the mental and behavioral health care crisis. And obviously these issues are not existing in a vacuum. There's a lot of intersection between them. In Maryland, we've especially seen this in the pediatric mental health space, where many children who have sought acute care have been forced to remain in emergency departments long after they are stabilized and ready to move to more intermediate care settings. And this is mainly due to the fact that there simply are not enough such settings for them to move to, in part because of the longstanding workforce shortages. Mr. Strozik, what impact does this have on the quality of care for children and the efficiency of the emergency services system as a whole, if you could speak to that?
Well, without a doubt, across our nation with COVID, we saw a significant impact to emergency facilities, ED departments across the country. Therefore, it was not uncommon to see 10 or more ambulances stacked outside a hospital ED with patients on board waiting to get admitted just to the ED, much less have tertiary care moving to the floor. In the case of pediatric patients needing to go to higher levels of care, there are a limited number of beds, there are a limited number of facilities. In return, as ambulances became backed up because of EDs were filled up with patients and there were no bed space, that delayed the transfer in some cases of patients needing to go to tertiary care. I think it would be an honest statement to say, if a patient absolutely had to go, it was a life and death scenario, our healthcare system made it happen. But it did delay the delivery of transfer of patients under less acute situations. And there can't imagine anything worse for the parents or the child to spending additional hours in an emergency room when they really want their child to be at the long-term care, be at the bed, in the hospital, receiving care needed.
And a lot of these bottlenecks in the whole system are traceable back, at least in part, to the healthcare workforce shortages that we're seeing. Because obviously, if you can't resource different things along the care spectrum, then you're going to have those problems. So the workforce shortages, coupled with increased demand for healthcare services, are further straining already overworked and understaffed emergency departments. That's leading to longer wait times for care for all patients and more burnout of our healthcare providers. Right now, in Maryland, despite concerted efforts to build pipelines and improve care that our Governor Moore, has undertaken, and our state agencies, Maryland has some of the longest emergency room wait times in the nation, actually. Something that we've been focusing on for the last couple of years like a laser. Mr. Feist, in your testimony, you note the CDC's October 2023 Vital Signs report found that 46% of healthcare workers experience frequent burnout and 44% intended to look for a new job within a year. Those are really jaw-dropping statistics, and they make clear that as we work hard to combat the broader mental health care crisis, we are facing one in its own right among healthcare providers, and you've talked about it today, and we know, for example, why it's so important to reauthorize bills like the Dr. Lorna Breen Healthcare Provider Protection Act. What I'm curious about, just have a minute left, is burnout as a concept is just getting a lot more focus, a lot more research behind it. Is there kind of an emerging field that maybe burnout isn't sort of a clinically defined condition yet? Maybe it is, I don't know. But what is the data and research delivering to us about this very specific topic of burnout, and can it lead to even more kind of out-of-the-box creative thinking about what the response should be for that particular situation?
Absolutely, and thank you for your support of our bill. What we need to remember is that burnout is not a mental health condition. Burnout is an occupational syndrome. It is driven by the work environment. So a lot of the key to addressing the root cause of burnout is to make the work environment a better place. There are cultural issues, there are leadership issues, but at the root cause of a lot of the burnout, in fact, the #1 driver of burnout year over year, pre-pandemic, during the pandemic, and post-pandemic, is the increased administrative burden that is placed on clinicians that take them away from the bedside, that take them away from taking care of patients and all of us. So what is emerging is this is an operational redesign problem for the healthcare industry to take on so that the workforce does not burn out in the first place.
Thanks very much. Yield back.
Thank you. Gentleman yields back. Chair recognizes Ms. Harshbarger for 5 minutes.
Thank you, Mr. Chairman. Thank you all for being here today. I'll start with Dr. Shih. Tennessee is home to one of the 16 autism and developmental disabilities monitoring network sites that are funded through the Autism Cares Act authorization. And as the other pharmacists in Congress, I have compounded many things for autistic patients over the years. My question is, can you speak to why the information derived from the network is so important both for Tennesseans and the rest of the country?
Thank you. Thank you, Representative, for the question and for your support of the bill. So the ADAM network has been instrumental in terms of shifting our thinking about autism in the United States. As Dr. Pike had mentioned earlier, the two cornerstones of public health is data and training. And until ADAM network came into being, we didn't have any data about autistic people in the United States. In the decade since, we have been able to collect data, longitudinal data, as well as cross-sectional data about our population, our community in the United States. And it has told us where the needs are the greatest, where we're seeing the greatest growth in terms of autistic population, where the gaps are in terms of services, and more importantly, what are the trajectory that we can expect from these children. The other thing that ADAM data has really shown us is really to highlight the disparity that exists within the community and between autistic people and neurotypical counterparts in terms of their experience in the healthcare system. So we know that, for example, children of color tend to be diagnosed much later than their white counterparts, even though that gap has closed, and that ADAM data has really shown us that. And there's still obviously a lot more work to do, and we think that the ADAM data will continue to help us provide that monitoring ability to help us understand whether or not the policy and program solution that we're introducing are actually making a difference.
Absolutely. You know, you talked about the co-occurring health conditions with these autistic patients and how they experience them at higher rates. So I guess further research can help us with all that. So.
Absolutely, yes.
Yes, sir. Mr. Strozik, you mentioned in your testimony a recent Department of Veteran Affairs final rule that could jeopardize our veterans' access to ground ambulance services. And I guess my question is, can you please tell us briefly what the VA payment system for ambulance services was before the VA issued the rule, and basically what's the payment framework now that the department is changing? And the reason I ask is I have a huge VA center in my district, and they service probably, close to 150,000 veterans, so.
Great. Thank you, Congresswoman. I appreciate the question. Today, the payment system is the same. It has not changed. There was a plan to implement the payment rule, which would change the reimbursement for ground ambulance services from the usual regulated customary rate in a community to the Medicare rate. And you can imagine the financial impact of systems around the country. The VA has delayed the rule until February 16th, 2025, a one-year delay on that. The challenge is that the VA has not specified nor defined how they are going to come back to that and look at the impact of this change between now and then. Congressman Bost and others have bills that would require the VA to do a study on the impact of this, both in terms of ground EMS services and air EMS services. We're asking that those bills be passed so that while we appreciate the one-year delay, it doesn't take the problem away.
No, I deal with this all the time. They push it down the road in my profession. You're asking for transparency, maybe? Yeah,
We're asking
well,
for a clear study and review so that the impact is clearly understood.
Gotcha. I understand completely. Dr. Annunziata, in your testimony, you referenced support for the Screens for Cancer Act, which would reauthorize the National Breast and Cervical Cancer Early Detection Program through 2028. And it'll give greater flexibility to grantees to implement innovative, evidence-based early detection and screening interventions. And, you know, I have noticed and read reports that there's been numerous reports on the concerning increase in cancer rates in young people, and especially in cervical cancer diagnoses in women between the ages of 30 and 44. Breast cancer as well in younger women. To me, that's deeply troubling. My question is, you spoke of greater flexibility, so how can we improve detection, screenings, and health outcomes with this bill?
I just want to say we have a scoreboard clock problem. The score on the field is, you got time, but just
Yeah,
after you answer
Brett.
this question, I'd like to answer a question.
Yeah, that's my last question.
Thank you for that question. So I think the short answer is that there are still women in the United States who are underinsured and who are uninsured who don't have access to these potentially life-saving screening services. These women have lower breast and cervical cancer screening rates. People without access to the screening obviously have lower screening rates, which means they're at greater risk of being diagnosed later and more advanced stages of the disease. So the American Cancer Society Cancer Action Network does advocate for this program because it's actually a gold standard for providing breast and cervical cancer screening, diagnostic tests, and treatment referral services to women with limited income and under and uninsured.
But even if you have some younger women with insurance, I mean, I had a pharmacist who worked with me, was 35 when she was diagnosed with endometrial carcinoma, and it's, you know, it's the ages in a lot of cases. They're not covering those preventative measures like 3D imaging or whatever on breast to detect early breast cancer. So we need to work on that.
Absolutely, we do need to work on that, and that's why more research is needed. We have clear data for people over 50, over 45 to have their screening. We need more data as to who's at risk in the younger populations.
Thank you. With that, I yield back, Mr.
The
Chairman.
gentlelady yields back, apologize for the clock, and the chair recognizes gentlelady from California, Ms. Battergown, for 5 minutes for questions.
Thank you, Mr. Chairman, and I think this hearing is a great hearing and the topic, and I want to just commend all our witnesses for the work that you do. It's great to have so many areas of health represented here and discussing how we can help caregivers and patients. I'm no stranger to being a caregiver, as I'm one for my mother who has Alzheimer's, and I often talk to my colleagues sometimes about me flying back for a day sometimes just because I have a caregiver issue at home, and the response I sometimes get is, how are you doing this, and being a member of Congress? And we are just like everybody else and have these challenges too. So it's so important that we look to see how we can support not just our patients, but our caregivers and their families as well.
I know during COVID, there was a long wait list for the federal government to help fund more in-home care under the WPCS program, something that I didn't even know about. And so one of the things that I want to make sure we're doing is figuring out how can we make sure that patients and their caregivers know about the resources out there, and something we have a lot of work to do. Dr. Pike, my questions are going to be directed at you. I want to thank you for your work in the Alzheimer's Association, for all you've done to advocate for our community. I'm encouraged by the progress made on groundbreaking innovation in diagnostic treatments and treatments for Alzheimer's. There are 53 million unpaid family caregivers in the U.S., and there are more likely to be people of color and women. The importance of short-term relief or respite care for caregivers cannot be understated. As I mentioned, when I travel to D.C., it's often making sure that I have a caregiver or a backup plan. Now, the Lifespan Respite Care Program provides grants to make quality respite accessible to family caregivers, but in addition to federal funding for the Lifespan Respite Care Program, how else can Congress support unpaid family caregivers?
Thank you, Congresswoman, for your strong and consistent leadership on this topic on behalf of our constituents. And I know it hits home personally for you.
Thanks.
I think one of the things that as we make decisions about the reauthorizations that we have in front of you, the bold reauthorization that does have caregiving responsibility and deliverables within it, the Lifespan Respite Plan and the grants that come along with it, we need to think about who those programs truly serve and how we get that to the community level. We often need to think about and consider the barriers to access the information about the respite program, the awareness that needs to be delivered around it, and the awareness that caregiving creates a need around in the healthcare system as well. So there are many ways that Congress can continue to consider the needs around respite, awareness and building awareness for those caregivers, the stigma that it holds, and building the tools, the grants and capability at the community level is incredibly important.
Well, thank you. One of the other issues that has come up, not just for me and others I've talked to, is the need to find culturally competent caregivers for different communities. How can the NAPA Act or other legislative proposals increase the availability of quality, culturally competent caregivers to support people with Alzheimer's or other illnesses?
I think of caregivers not only as the family caregivers, but also our paid caregiving workforce as well. And I think there's ways that we can build education and resources at the community level that build capability within both of those caregiving populations. The paid caregiving population is unique in that we learned a lot during COVID on how to build capability and how to extend education beyond the typical walls of education and training. In particular, telementoring is another way to think about building the caregiving infrastructure with our paid caregivers, whether they are primary care or advanced practitioners long-term. A great example of a telementoring program that builds that capability is Project Echo, and the work that we have seen within the primary care, the advanced practitioner space, but also within the dementia care community long-term in building knowledge, awareness of the tools in the community, but also the education to create more specialist level care within our primary care and advanced practitioners around the country.
Great, thank you. I yield back.
The chair now recognizes Representative Pence for 5 minutes.
Thank you, Madam Chair, and thank you to the witnesses for being here today. We are considering several bills today that would improve the health and well-being of patients and support caregivers, including legislation focused on Alzheimer's disease. The Bold Infrastructure for Alzheimer's Act, championed by my good friend, Mr. Guthrie, would ensure HHS continues to have the resources and infrastructure needed to support the prevention, treatment, and care for patients with Alzheimer's. Alzheimer's disease is a brain and cognitive disorder that robs people of the capacity to live their lives to their fullest.
Symptoms are typically gradual, evolving to a point where they interfere with an individual's ability to complete basic tasks and enjoy relationships with loved ones and members of the community. The NIH currently ranks Alzheimer's as the 7th leading cause of death in the United States amongst older adults. In Indiana, there are 110,000 people aged 65 and older suffering from Alzheimer's, and 2,200 Hoosiers have tragically lost their lives to this terrible disease in 2021, according to the CDC. Innovators in the Hoosier states, such as Eli Lilly and Roche Diagnostics, are leading the charge to develop reliable testing and therapeutics. It's important we continue to support and invest in the programs and strategies necessary to ensure continued innovation in the fight against Alzheimer's. Dr. Pike, this question is going to be for you. Now that we have FDA-approved Alzheimer's therapeutics, I've urged the Biden administration to provide access to these critical drugs. While Medicare has traditionally covered all FDA-approved drugs, CMS has now set up a registry portal that could create logistical challenges for patients and caregivers, as well as providers in rural areas. Can you explain what current regulatory policies serve as a barrier for patients to efficiently access these treatments, such as a national coverage determination reconsideration, and how can we streamline and improve this access?
Thank you, Congressman Pence, for the question. I think this is an incredibly important time period to talk about the advances that we are seeing in Alzheimer's research, what is coming out of the pipeline, and ensuring that access gets to the patient level. As you mentioned, we are in a unique situation in that for the first time we have FDA-approved treatments. However, CMS has limited access to those through a coverage with evidence development policy on those treatments. As this committee may be aware, the Alzheimer's Association actively requested CMS to change their position on this coverage with evidence development, on this national coverage determination. Right now, the requirement for patients is that they access treatments through a registry. We want to see that there are as few barriers to accessing treatment as possible. We have seen as part of these treatments being available in community that any barrier potentially limits access, including whether it is knowledge about reimbursement or accessing a specialist in a community. So agree with you that there needs to be immediate access to any FDA-approved treatment.
Got any ideas how we could make that immediate?
I think there's a couple of things that we've learned, certainly. The healthcare infrastructure is not, we learned in the last about 12 to 18 months that the healthcare infrastructure needs support in order to make sure that access is immediate. But the other side of that is looking at the evidence and being able to say that coverage should not be limited by utilizing a registry.
Yeah, sure, and you know, in rural areas where it's a little hard to get to the folks and educate them, makes it a little more important since I'm in a rural area. And with that, Madam Chair, I yield back.
Thank you. The chair now recognizes herself for 5 minutes. And I'm going to thank all the witnesses for being here and for the real chair for having this hearing today. Ms. Whitten, I co-led H.R. 2923, the Living Donor Protection Act, which would prohibit life, disability, and long-term care insurance companies from denying or limiting coverage and from charging higher premiums for living organ donors. Amend the Family and Medical Leave Act of 1993 to specifically include living organ donation as a serious health condition for private and civil service employees, and direct HHS to update their materials on live organ donation to reflect these new protections and encourage more individuals to consider donating an organ. Can you or any of the other witnesses speak to the importance of encouraging organ donations and why it's a cost-effective solution in the long term?
Just to be clear, I'm not an organ transplant donor expert, but I do run the Global Down Syndrome Foundation, and we've found discrimination on both ends. In terms of donating an organ and then receiving the organ. And clearly, both are prohibiting life-saving organ transplants. So I think from our perspective, we totally are appreciative of the bill. We need to call out discrimination in terms of accepting organ transplants and then receiving those organ transplants. And it's kind of a no-brainer to us that, this is life-saving and it needs to be encouraged across the board.
To follow up on that, I also co-sponsored the Charlotte Woodward Organ Transplant Discrimination Prevention Act, which prohibits entities from determining that an individual is ineligible to receive a transplant or related services based solely on the fact that the individual has a disability. Currently, 40 states across the country have non-discrimination laws in place, which would prohibit transplant stakeholders from discriminating against individuals with disabilities. Why do we need a federal law?
Wow, and I wanted to call out Charlotte, who's here today. Happy Valentine's Day, and she had a heart transplant. And we have to fight for these kinds of things. 40 states have it, 10 states don't. The consistency of how the law is implemented needs to be addressed on a federal level. Also, in terms of litigation, if these things are happening where they're discriminating, that has to be done at a federal level as well.
Thank you. Mr. Feist, as a physician, this topic is very important to me. According to the Heroes Foundation, more than 400 physicians die each year by suicide, and rates of physician suicide differ by specialties. Notably, Dr. Lorna Breen, Healthcare Provider Protection Act included Section 764, programs to promote mental health among health professional workforce, to the Public Health Service Act. Under this section, HHS awards 3-year grants and contracts to healthcare entities to establish or enhance evidence-based or evidence-informed programs dedicated to improving mental health and resilience in the profession. What evidence-based interventions have been employed to date, and have you seen improved outcomes?
Yes, we have seen improved outcomes. I just want to be clear, the organizations that are convening those are IHI and GW, and they've given me some notes for today. So we've not been right at the center of that, but we certainly have reports. From an organizational change perspective, what we've seen is that leadership is getting training and support that they didn't have before, and that cascades down to the workforce environment, which drives burnout. We've seen engaging healthcare workers in advancing solutions, and I would say that because often the workers are less included in just finding out what the solutions are to do things that drive burnout, like reducing administrative challenges, addressing work-life challenges, as well as improving team-based care models. So those are some of the examples that have occurred. But what I want to point out is that there are over 6,000 hospitals in this country, and 44 so far have received our programs. So we have a very long way to go to scale these programs and to really make that impact on the workforce that we need.
And Mr. Strozek, I'm both a veteran and a doctor and a former director of the Iowa Department of Public Health, and EMS fell under our purview. You've discussed, and I'm also on the Veterans Committee, so this is an important question, follow-up from Ms. Harshberger. You've discussed several significant challenges facing ambulance agencies, including staffing shortages and insufficient reimbursement. We've also heard a lot about drug shortages on this committee, particularly in generic sterile injectables and pediatric cancer. However, we know that injectable drugs are very important in EMS, and can you share your thoughts on the impact of drug shortages on emergency medical services?
Yes, I can. Thank you, Congresswoman. It's hard to imagine that we would have a difficulty finding things like injectable epinephrine to deal with anaphylaxis, that we would just sterile solutions for clearing lines. We've run across other cardiac medications we can't get. And in turn, you may recall that when the hurricane hit Puerto Rico, we were unable to get quantities of sterile saline solution in bag form as made by one plant. So this continues, and it seems incredible that it does today, that we have this rolling shortage of medications, up to including pain relief medications and certain narcotics. So it continues. The National Association of Emergency Medical Physicians, NAMSP, this is a critical agenda item for them, and we look to support any work that can be done to go forward.
Thank you. I've gone over. I yield back. The chair now recognizes Representative Crenshaw for 5 minutes.
Thank you, Madam Chair, and of course I want to say to the chairwoman who's retiring. Thank you. I don't see her here, but I want to say thank you for her service, and she will be sorely missed. Pleased to be focusing today on traumatic brain injury. A lot of personal friends have suffered from TBIs. They've served our country in the armed forces. They've served our country in law enforcement, and they live with these injuries for years. 5 million Americans live with a TBI. In the military, the estimate is that 30% of our service members experience some type of brain injury, and it's similar in law enforcement. We think that a third of veterans have PTSD, a fifth of police officers have PTSD, and they're definitely linked to TBI and the symptoms that they face every day. It's a lifetime of issues, and so I think we should be supporting and funding more research for those who are injured, and I echo Mr. Strozik's remarks about reauthorizing programs to support that research. We also have to do our best to make sure that that information just doesn't stay in an agency in Washington, D.C., but that best practices filter down to all practitioners. Mr. Strozik, you're a first responder. What do you see as the biggest gaps in identifying TBIs early on?
Well, Congressman, thank you. If we speak in terms of EMS providers, or we speak in terms of public safety, law enforcement, or fire service, it may be identification and acknowledgement that something's happened. So be it an accident where there's been an airbag deployment, there's been a fall, there's been something that would trigger a reason to do an evaluation needs to be established. The military has done a marvelous job, and unfortunately has had to, recognizing and identifying traumatic brain injury. I refer back to a comment I made earlier in our presentation that motorsports and youth sports have become extremely focused on identifying initial signs of TBI and doing secondary and tertiary follow-up on this. I would think, and I would hope, and I would look forward to physician groups, NAMSP, United States Fire Administration, other groups that are involved in this, and also neurological groups, that we establish standards that says if A, B, C, or D has occurred, then that person must receive a screening, an initial screening and a backup screening.
Yeah, and you know, I don't need to tell anybody this, but the reason it's difficult too is because if you don't have a baseline to operate off of, so in the military, I know that we started doing baselines a long time ago. I don't know if that's the case in law enforcement. Dr. Pike, another one of the worst diseases we see in the TBI space is CTEs. People with CTEs are also 2 to 4 times more likely to get dementia. Can you share your opinion on the barriers to diagnosing these difficult diseases in the brain?
Thank you. The relationship between TBI and CTE is a growing area of research, certainly, and like Alzheimer's, CTE is characterized by tangles of an abnormal form of the protein tau in the brain. And evidence, as you just mentioned, indicates that even a mild TBI increases the risk of developing certain forms of dementia. In fact, recent results have shown a 70% increase of dementia risk from any form of TBI. But the fact is, more research is needed. We need to understand CTE diagnosis and prevention, and another way of early identification within that space. We also need to think about the investments within the workforce and training within the workforce for the earliest signs and symptoms of TBI and the connection to CTE. And that's exactly why we're requesting to reauthorize NAPA and the Alzheimer's Accountability Act.
Okay, I appreciate it. I want to end with a conversation about breast cancer. It's deeply personal to me. I lost my mom to breast cancer, and early detection can be life or death. Dr. Annunziata, what role do you see for diagnostic innovation in solving this problem?
Yes, we certainly need more innovation in the diagnostic sense. The American Cancer Society recommends traditional screening for women at risk of breast cancer, and those are based on data that we've collected over the years. But American Cancer Society does also support that any test recommended by a doctor or in a study recommended for women with, for example, with dense breasts, should be covered at cost sharing. And we're pleased that the FDA finalized a rule last year specifically requiring all mammogram reports to be sent to patients and doctors to include information on dense breast.
Got it. Thank you, and I'm out of time. I yield back.
Thank you. The chair now recognizes Representative Tonko for 5 minutes.
Thank you, Madam Chair. And again, I am so honored to stand with the Alzheimer's community and champion many of their efforts. Given the enormous impact of Alzheimer's on my community, this summer I proudly hosted a public discussion that we called The Faces of Alzheimer's Disease in the Capital Region, where we did a spotlight of the local experiences of patients, their families, and caregivers. I heard from Beth Smith-Bovin, who, as the leader of the Alzheimer's Association of Northeastern New York, introduced us to Eugenia, who was there to give a face to Alzheimer's, as well as her husband, Dick, who serves as her caretaker. And we were welcomed also by Sherry and Ginny, who also both care for spouses living with Alzheimer's. We heard from the neurologist, Dr. David Hart, and from Nancy Cummings, the Center Director of Alzheimer's Center at Albany Med, as well as many others. To everyone who participated, I thank them for providing a face and a voice to Alzheimer's. To the Capital Region community living with Alzheimer's, I see your pain and struggles, but I also see your strength and your resilience. I fully recognize that we must do more and provide much-needed hope. In that vein, I'm thrilled to see the increased investment in Alzheimer's and dementia research funding at the National Institutes of Health. And I'm glad to see how the Alzheimer's laws we are considering for reauthorization today have helped lead us here. But with over 410,000 individuals in my home state alone facing this devastating disease, it is clear that not only funding, but a strong national strategy for prevention, detection, and treatment is necessary on a federal level to help districts such as mine respond to this growing threat to the health of our country. During my first term, I was proud to support the National Alzheimer's Project Act. A decade later, NAPA allowed us to establish a federal plan to address Alzheimer's and dementia that was successful at bringing coordination and attention to the disease. However, those essential federal programs are soon set to expire. I am proud to help lead the bipartisan National Alzheimer's Project Act Reauthorization Act. I also strongly support incorporating provisions that more robustly support and include populations that experience Alzheimer's disease and related dementia at a rate that is markedly higher than the general population, such as individuals with Down syndrome. I'm also proud to co-lead the Alzheimer's Accountability and Investment Act, which ensures scientists speak directly to Congress on resources that they need to effectively treat the disease. So, Dr. Pike, can you speak to the importance of the national plan to address Alzheimer's disease and the Alzheimer's bypass budget? How do these blueprints together play a role in equipping researchers with the funding that they need to effectively prevent, continue to treat, and one day cure Alzheimer's?
Thank you. Congressman Tonko, your leadership and even the storytelling that you do within your own community is amazing for the work that we have seen and the progress that we have been able to make. NAPA and the Alzheimer's Accountability Act have led to significant progress within the Alzheimer's community, and certainly robust and steady investment. Scientists have been able to work faster to advance basic disease knowledge, explore ways to reduce risk, uncover new biomarkers for early diagnosis, and develop national treatments. Due to the creation of NAPA, that national plan, and the work of the bypass budget since 2014, research funding for Alzheimer's and dementia at NIH has increased more than 7-fold over the past decade. And the work of both of these bills has been crucial over that decade to continue this important work among and to coordinate all of the agencies within the federal government. So
thank you. I'm also honored to lead the efforts once again on the BOLD Infrastructure for Alzheimer's Reauthorization Act, along with my good friend Congressman Guthrie. This effort, as we know, will allow us to continue to strengthen our Alzheimer's and dementia public health infrastructure across our nation. So, Dr. Pike, again, you discussed in your testimony how the CDC awards through BOLD have made real-world impacts in many states. Can you share some more examples of this type of innovation, particularly perhaps examples from my home state of New York?
Yes. And New York has been a leader within the public health space for quite some time, both at the state level and within the application of CDC funds. Since 2018, CDC has established 3 Alzheimer's public health centers of excellence, and one of which, the Center on Early Detection, is based at New York University. Most recently, in September of 2023, CDC funded 43 public health departments across the country, including New York State and New York City. New York State Department of Health proposed an initiative to expand dementia-related services statewide, resulting in the New York Alzheimer's Disease Caregiver Support Initiative. Within this initiative's first year, community support services for people with dementia and their caregivers reached approximately 13,000 individuals and families. Through the public health initiatives such as these, and certainly the Center of Excellence at New York, we know that New York continues to lead the way in the fight against Alzheimer's and other dementia.
Thank you so much, and it's obvious that we need to continue to invest through the federal government in research on behalf of Alzheimer's. So I thank you, and with that, Madam Chair, I yield back.
Thank you. The chair now recognizes Representative Kamick for 5 minutes.
Thank you, Madam Chairwoman, and thank you to all my colleague that are here. I know that I'm here at the tail end, but thank you to all our witnesses for appearing before us today to talk about these very important issues. I am thrilled to see my bill, the Charlotte Woodward Organ Transplant Discrimination Prevention Act, included in today's hearing. Now, as many people know, that this bill, it was named for Charlotte Woodward, who is with us here today somewhere. There she is. Hi, Charlotte. An adult woman, an amazing woman with Down syndrome who is with us and is with us today because of a life-saving heart transplant over 12 years ago. Now, sadly, not all individuals with disabilities have that same opportunity. This issue is one that has become personal for me. As one of my constituents, Bobby and Josh Saramento, they are loving and devoted parents in Ocala, Florida. They lost their son, baby Zion, who was born with Down syndrome and in need of a heart transplant at just 6 months old. Zion's family were told that his life did not have the same value as mine or yours, and was subsequently denied a heart transplant because of his disability. This is unacceptable. Ooh, I get ya. Charlotte's bill would seek to prevent this type of discrimination from happening and creates an avenue for timely relief at the Office of Civil Rights at the Department of Health and Human Services for those who have been discriminated against. I want to thank my colleagues across the aisle, particularly Congresswoman Debbie Dingell, for leading this important priority alongside me. And of course, at this time, I would like to submit a letter of support for this bill led by the National Down Syndrome Society and signed by over a dozen disability advocacy and organ transplant stakeholder groups. Thank you. And with that, I'm going to jump right into a few questions. Ms. Whitten, where are you? There you are. You mentioned in your response to Representative Dingell that it is clear that legislation is needed in states that do not have a non-discrimination law in place for individuals with disabilities. For patients who are discriminated against, could you please briefly explain what relief a bill like ours would provide?
Yes, thank you so much. And also just from a background, my daughter who's 20 who has Down syndrome, when reading about the history of, say, baby doe, where a life-saving procedure was feeding a baby with Down syndrome in a hospital and legislation had to be passed so that you couldn't starve a baby to death. I mean, that was just in the 70s, and then Willowbrook was only shut down in the 90s. So, we've got this whole human rights thing going on, and so your work, Congresswoman, is just so meaningful for our families and for me. Yes, it's important to be able to actually litigate, right? If you're being discriminated against, going to the Office of Civil Rights and presenting your case. So that wasn't possible before, certainly in the 10 states that didn't have any laws, and then the consistency of which to do that now at a federal level is just profoundly impactful.
Now, and one of the concerns that we've heard repeatedly on the bill is regarding what effect the provisions would have on the current practices of physicians. So how would this bill impact, or preserve, I should say, preserve a physician's role in the transplant process?
It's important. We're not getting in the physician's business and telling them how to make decisions, but we have found again and again that there are people, physicians, who have, based solely on the diagnosis of Down syndrome or disability, said, no, this person is not qualified to be a recipient. And so this addresses that. It doesn't take away the ability to look at the whole medical profile and make a decision, based on how that transplant will, be received over time. But that's what we're doing. We're getting the worst discrimination out there, and we're still preserving the rights of the medical professional.
Thank you for making sure that that is on the record, that we still preserve that autonomy. But as a follow-up on top of that, 2019 National Council on Disability report highlighted that many transplant stakeholders believe individuals with Down syndrome cannot adhere to post-operative care. Therefore, they are risky candidates for transplants. Is that an accurate assumption?
No. I think that with people with Down syndrome, many of them have a support system that has to be taken into account. And if you just said, oh, this person, can they do self-care? I don't know that I could do the self-care or that a lot of people could do the self-care. We all have a support system. So this law or this legislation will address the fact that there has to be a support system looked at, not just that individual.
Thank you so much, and thank you to all of the wonderful advocates in attendance today. I believe Charlotte Woodward will be a member of Congress one day, so shout out, and thank you, Madam Chairwoman. I yield.
Thank you.
Thank you very much. The chair now recognizes Representative Castor for 5 minutes.
Thank you, Madam Chair. You're about at the end now, so thank you. Thank you to all the experts who have stuck with us today, and thank you to all the patient advocates and caregivers and families and the medical professionals who support them. It takes a lot to get legislation to committee and then get it actually heard in committee and get it moving along. So congratulations to you. We have a little more to do, though. And I want to thank the committee for including 2 of my bipartisan bills, especially the bipartisan and bicameral Shine for Autumn Act. This bill is not new to the committee. We passed it before, but the necessity for passing it into law remains urgent. The bill is named after Autumn Joy, who was born still on July 8th, 2011. And her mother, Debbie, has turned Autumn's tragic death into a mission to increase stillbirth awareness and education and ultimately decrease the number of families who experience such a heartbreaking loss. Stillbirth is a public health crisis in the United States with over 21,000 stillbirths every year. That's almost 60 babies every day. This exceeds the number of deaths for children aged 0 to 14 from guns, accidents, preterm birth, SIDS, drownings, fire, and flu combined. And like too many other maternal and child health issues, there are persistent and long-standing disparities with Black women more than twice as likely to experience stillbirth as white women. At least 1 out of every 4 stillbirths are estimated to be preventable, but there's still so much that we do not know. That's why we need real change that will lead to measurable improvements in the outcomes for families. The Shine for Autumn Act would improve surveillance and data collection relating to stillbirth nationwide and invest in research to examine the causes and risk factors. Additionally, it would seek to increase education and awareness. American parents deserve better data and science to help improve pregnancy outcomes. And I'm proud to lead this legislation with my colleagues, Reps Young Kim, Robin Kelly, and Dave Joyce to keep the memory of Autumn Joy alive. Together, our committee can address the serious maternal and infant health crisis that is tearing families apart and causing significant pain and trauma. At this time, Madam Chair, I'd like to ask unanimous consent to enter into the record testimony from Debbie, who has really spearheaded this effort, and I know she is watching and listening today. And a thank you from the 300-plus endorsing organizations of Shine for its inclusion in the hearing.
No objection.
We need a clearer picture on why babies are dying if we want to make progress towards reducing stillbirth rates and improving outcomes. With timely and accurate data, we can begin to understand the underlying causes of stillbirth and guide policy actions and much-needed strategies for prevention. I'd also like to highlight another bill of mine on the agenda, H.R. 6960, the Emergency Medical Services for Children Reauthorization, which I led with Reps Carter, Schreier, and Joyce. Our bill would reauthorize the vital EMSC initiative for another 5 years at the current funding levels. I I have the privilege of co-chairing the Children's Healthcare Caucus in the Congress, and I have learned over the years from a lot of folks like you that children have specific healthcare needs, including in an emergency when there is little time to spare. For the past 40 years, EMSC funding has spurred innovation and advanced research to address the unique needs of children in emergency medical systems, saving countless lives and improving health outcomes. EMSC benefits children every day, in every state, in every territory. And here's an example. Back home in Florida, EMSC served 4.3 million children and their families. You all may remember that monster Hurricane Ian when it was bearing down on southwest Florida in 2022. They evacuated 81 critically ill neonatal and pediatric patients from local hospitals. And we knew that the transport vehicles were properly equipped at that time thanks to Florida EMSC Safe Transport Work Group's earlier distribution of hundreds of pediatric restraint devices. Using this kind of resource, it allowed the Disaster Response Committee to develop a pediatric mass casualty triage tool that has been distributed. So I'm grateful to everyone that has worked on this. Thank you very much. And I'd also like to ask unanimous consent to submit for the record a letter of support from the endorsing organizations for HR 6960. And thank you.
No
all
objection.
very much.
The lady's time's expired. Does she yield back? Thank you. I ask unanimous consent to insert in the record the documents included in the staff hearings document list. Without objection, that will be the order. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond to their questions promptly. Members should submit their questions by the close of business on February 28th. Without objection, the subcommittee is adjourned.